I would like to welcome you to this amazing online course about a multifactorial topic of the immediate implant placement in the aesthetic zone. And here to discuss this topic with us are Dr. Dennis Tarnow and Dr. Abdelsalam Elaskary. Dr. Abdelsalam Elaskary is the founder of the Elaskary and Associates Clinic and Educational Institute located in Alexandria, Egypt. He's currently a visiting lecturer at the University of New York, NYU. He authored 3 textbooks in the field of dental implantology and oral reconstruction, reconstructive aesthetic implant surgery, fundamentals of aesthetic implant dentistry, and advances in aesthetic implant dentistry, all published by John Wiley and translated into several languages. In addition to that, a rich contribution to the literature by numerous published articles in recognized reputable journals. He's a member of the editorial review board of the International Journal of Oral Implantology. And also I'm going to introduce Dr. Dennis Tarnow. Dr. Dennis Tarnow is currently clinical professor of periodontology and director of implant education at Columbia School of Dental Medicine. He is the former professor and chairman of the Department of Periodontology and Implant Dentistry at New York University College of Dentistry. Dr. Tarnow has a certificate in periodontics and prosthodontics and is a diplomat of the American Board of Periodontology. He's a recipient of the Master Clinical Award from the American Academy of Periodontology, Teacher of the Year Award from New York University, and Distinguished Lecturer Award from the American College of Prosthodontists in 2015. Dr. Tarnow has a private practice in New York City and has been honored with a wing named after him at New York University College of Dentistry. He has published over 175 articles on perioprosthodontics and implant dentistry and has co-authored 3 textbooks, including one titled Aesthetic Restorative Dentistry. Dr. Tarnow has lectured extensively in the United States and internationally in over 45 countries. So with this, first, we're going to go ahead and start with Dr. Abdelsalam Elaskary. Thank you so much for being with us, Dr. Abdelsalam. It's a pleasure having you with BioHorizons. And I'm just going to go ahead and give you the mic so you can share with us the amazing cases that you have.
Thank you very much, ladies and gentlemen. Good evening, everyone. I hope you're fine, you're safe, and I hope everybody is safe by now. I would like really to take this opportunity to thank BioHorizons and to thank all of the organizers that put up this program together. It's a wonderful program, and it's a wonderful idea to be with, let me call with Dennis, because he is, it's an honor to be with such a professor on this platform. Our topic today that we have decided to share is about managing fresh extraction sites in the aesthetic zone. It's a wonderful topic, and I think it's a hot topic as well. For this, we really thought that we should make some ideas on what is the immediate implant placement have revealed to us in the aesthetic zone over the years. As you can see here, this is a case on January 2005, immediately restored with dental implants. But if you follow this up, 3 years later, what happened here? Catastrophic. So we started to follow up cases, and we started to realize that our poor understanding of the socket physiology and anatomy, as well as the tissue response to trauma, was really the main reason behind the errors that we keep seeing. And of course, I can see this every day. I see all of these results as a result of poor clinical management of immediate implant placement in the aesthetic zone. It's a delicate procedure. It's really very difficult to tackle. And I have found out that there are some key factors that really influence the procedure of implant placement in the aesthetic zone. One of these keys is the osteoclastic activity. When we come to osteoclastic activity, it really involves all of the steps of the treatment that starts from the tissue response to trauma, for example, the tooth extraction, the tissue response to the type, the phenotype itself, and the management to surgical wound, as for example, the mucoparietal flap reflection. As you can see here, it starts with aggressive extraction. You can lose the soft tissue, or you can lose the bone with taking the tooth out. Just very simply and very easily, you can lose the bone or you can lose the soft tissue. That indicates how delicate the procedure is in order to get the good prognosis. And when we say good prognosis here or a good outcome, it means that a long-term one, not just a good, nice out-looking case that looks good in 45 minutes. No, we're talking about 1 year minimum or 2 years. Another thing is tissue phenotype. Tissue phenotype is really what influences the whole idea of immediate implant placement. Thin phenotypes really increase the osteoclastic activity by inducing further resorption of the labial plated bone. That is definitely confirmed by the literature, as you can see here down below on the reference. So once you have a case like this with this thin phenotype, then you need to question yourself, am I gonna put an implant here only without any other intervention, or I need another scenario? Look here, this is a very thin case, and look at this implant being placed here. What really I expect this. This is what I expect. I can show you hundreds of cases that you can see without enhancing the soft tissue prior or along with implant placement, you will end up always like this. Doesn't matter when, but it's going to happen. Today, tomorrow, after 1 year, after 2 years, but it's going to happen. I can show you several cases. This is 1 month, this is 3 months case with thin scallop tissue phenotype, and at 6 months type, that's what happened. So I really would like, if you want to take out home message with you, is you really need to influence and to enhance your soft tissue status along with immediate implant placement all the time. That's something that is really solid and we really need to take care of. The thickness of the labial plated bone. I know that all of you are acquainted and know about thickness of the labial plated bone, and it has been covered by so many authors in the literature. However, I would like to emphasize the fact that if we say thick labial plated bone, how thick? And if we say thick labial plated bone, where? At the crest, or at the middle, or at the apical area here? That's a question. We really need to realize that once you have a thin labial plated bone, you do the tooth extraction, resorption occurs. And I know that all of you know that. It's because of the thin crest of the bone, lack of the blood supply, as well as the osteoclastic activity that we have covered before as a result of flap, reflection, or tooth extraction, etc. And you need to realize one thing that is very important, which is that if you see a case like this with abundant mucosa and abundant bone, this is only less than 5% of what we see nowadays every day. I know that there is an advantage from the thick labial plated bone. It has some sustained wound space, and you will never fail having a case like this. But you remember that this is only less than 5% of what we see every day. One more thing, which is the implant position. Implant position has 4 different categories. As the diameter of the implant itself, the selection of the diameter, the angulation, the spacing, and the guidance. How are we gonna put all of these 4 issues together? And I'm showing this video to you here just to realize the fact that this is the main error that causes faulty implant positioning, is the slippage along the architecture of the socket anatomy itself with the pilot drill. So once you do this arbitrary, what I call this term arbitrary implant placement. You see this case, you see this result all the time. If you leave your drill slips like that, you will end up with violation and improper implant placement. So now, arbitrary implant positioning, you can position the implant, yes, and you can have wonderful case, wonderful prosthesis, excellent. But look at the X-ray. I'm not sure that any of us will be able to do this arbitrary implant positioning and get 100% or even 70% of implant position that is correct. So I'm not sure that anyone should do that. Arbitrary implant positioning with flapless implant positioning is a complete contraindication. The labial gap is something that we should also watch out for in immediate implant placement. No one will be able to cover this gap better than Dr. Tarnow. But let me just touch up a little bit of other issues in regard. The size of the gap, the proximity of the implant towards the labial edge of the labial plate of bone, that's something that we have to really watch out for. So what if we have an implant that is touching the labial plate of bone, as you can see at the X-ray here? What do we expect? Do we expect it to be like this and to stay like this? Let's see. This is December 2016, and this is February 17, and this is April, and then we go to May. What happens in May here? We lost the labial plate of bone. So this is something that really we have to anticipate. The size of the implant, the diameter of the implant, it has to do a lot with the size of the labial gap that we really need to take care of. That takes to generalizing the term with using when saying wide diameter implant. So do we use these wide diameter implants anymore in the aesthetic zone? Of course not. Why? Because we lose the bone. The more you get closer to the inner surface of the labial plate of bone, you lose the bone right away. That's something that we know for sure. Look here, I always see cases like that, and I don't think twice to remove these implants because these are failed implants. I remove the implants, I exchange the implants with narrower diameter implants. Now I can have a labial tissue bulk. The labial tissue bulk that has been identified and stated by Oli Grunder, and he's one of the people who published on this subject, and we'll get to this later on during the presentation. But you can see here, once you provide the labial bulk is the soft and hard tissue together. Once you bulk this together, then you will have a better outcome. Here is another problem. Here's another issue. Using a wide diameter implant led to the extreme loss of the labial plate. And you see, this is the violation also in the position. The only way to treat this is to regain the natural emergence with a lower profile diameter implant, graft with whatever graft that you like to use. I use here, this is it's called composite graft that is hard and soft tissue together. And for whom that are interested in this type of graft, you can just check out the chapter. There's a special chapter in my book for this type of graft. And here's the case and followed up for 3 years later down the road. You can see better aesthetic outcome with very nice emergence. So once you restore the position, then you will get up with a very good aesthetic outcome. And you just need to realize that I've done like a retrospective study for myself, not a study, but like a search. For the past 5 years, I never placed more than 4.2 millimeters diameter in the aesthetic zone to restore an implant in the aesthetic zone. You can see here, so you don't even think twice of using more than 4.2 millimeters diameter in the aesthetic zone. That's something that we know for sure now, and I want you to take this step back home for you. Now we get to another question with, what am I going to fill this gap with? I need to fill this gap. First of all, do I fill it? Debatable question. If I will fill it, what I'm going to fill it with? I'm going to fill it with something. But for example, let me ask the question, how does an optimal regeneration looks like? If I want to regenerate this bone here, how does it look like? A good bone, a good predictable. This is how it looks like. So just to know that this is a normal bone, this is what we call a real regeneration. How could such regeneration be achieved to have a case from this situation to that situation? That's what we call a real regeneration, not a chauvinistic regeneration. That's a big difference. So what I use here is what I call osteogenic graft, which is 75% of autogenous bone chips with 25% of this bone that is 25% filler of deproteinized inorganic xenograft. It's the capacity of the graft itself. So I use the particles to show that it has 75% of chips that is full of growth factors and full of bone forming proteins, and then I use the xenograft to get the physical character of the graft. So this is what I do usually. I just go to any place to harvest the chips, or I just go to even the nasal spine to harvest the chips. So the chips is really important in order to maintain your osteogenic graft capacity. And here what we do, this is what we do here. Simply we put the 75% of the chips along with the deproteinized bovine bone. This is what I use all the time, and I fill the socket with. But why cortical chips? Why chips? Chips has been investigated in the literature several times. First, it has a fast relief of TGFs, and also it has the osteogenicity, and it has osteoinductive capacity and osteoconductive capacity as being studied in the literature. Also, the Rick Myron study that is really famous, when he followed up several types of bone grafts, autogenous chips, scrapers, slurry, piezo, and the mill, and he found out that the chips are the highest that exhibited significantly higher level of collagen, osteocalcin, ostrix, and produced more mineralized tissues over 5 days. So this is a study that is really has giving us an idea why would we use the chips. What is the size of the chips? The size of the chips, you really need not to go less than 0.5 millimeters, and you need not to go over the 2 millimeters, because it has been studied in the rabbits, and we find out that the average size should vary from 0.5 to 2 millimeters. That is seen to be preferred. One more thing that you could put some, you can add some osteogenicity to your graft by putting the serum. Serum is the serum of of blood from the bone graft itself, from the autogenous serum. You add it. Some people prefer to add Ringer solution to the serum 1:1, and they call this BCM, the bone conditioned medium. It has been studied by Maria, Daniel Boozer, studied by others, studied by many. Just induce a phosphorylation that really integrates or stimulates more regulating to the protein function, transmitting signals throughout the cells that probably boost the osteo regeneration. And why deproteinized inorganic xenograft? It's just because it gives a physical character to the graft, minimize the remodeling rate, and it also has proven to be a good or a great regenerative material in GBR practice, that being studied in 2018. The particle size also that you should select for your graft, for your bovine graft, it should not really get less than 100, because if you get the small particles, it electron microphage response and rapidly resorb. And if you go above 300, Well, the average size is from 1 to 5 is to 1,000 microns. I personally prefer between, when you choose between 100 and 300 microns. Now, what is the implant size that I should choose? And what's the implant physical characters that should I choose? First, I should choose a platform switch connection. That's for sure, and everybody is agreed on that. And you could also choose sharp, aggressive threads that allow a very good primary stability. And you can use one of those one-time abutments. And you can use laser-etched collars, implants that enhances the fibroplastic adhesion to the collar that has been proven by many speakers, by many authors, and narrow diameters implants that we have decided before. This is one of the new implants by BioHorizons called the Pro, one of the unique designs that has already platform switching with aggressive, tremendous, very nice stability, very nice platform switching, and also fibroplastic adhesion as a result of using the laser etching. This is also another abutment that you might be interested to use one time, is the laser etched base abutment. You can use these abutments and put it there, just let it there all the time. This is something that stabilizes your bone, stabilizes your tissues all the time, and we really like that very much. If we can do immediate implant placement. Off the topic, I had the pleasure to join BioHorizons in developing this design, the implants for fresh extraction sites, but in the posterior zone, those wide implants. I have the pleasure to design it with my friend Fred Maltz from BioHorizons and his team. We used to do those teleconferences starting from January, I think July 2014, we started to do the sessions until we came out with this unique solutions when we have this big sockets, no interceptal bone. What do we do here? Do we graft? Do we wait? So this would really engage the both cortices of the alveolar process, and you really can use this aggressive threads to engage both cortices. It really works well. I am very proud to be one of the designers of this implant, and since this implant came out, I have, along with the Pro, of course, I have tremendous outcome with this. Back to the subject. What are the available therapeutic protocols that offer to treat fresh extraction sockets with immediate implant placement? So we know that there are so many procedures that has been offered in the literature to treat immediate implant placement with variable degrees of resorption. We have conventional flapless methods, the one that everybody uses, including myself. We used to do that, put the implant with the bone and then condense it. Mucoperiosteal flap reflection going really wide or maybe going more aggressive. And dual zone grafting, and we have the boss of the dual zone and ice cream cone technique, Dennis Tarnow, who invented this, socket shield and contour augmentation. So what's wrong with putting an implant like this and putting the bone and leave it like that? Why we don't just do this anymore? We just don't do this anymore for many reasons. This is something that is completely unpredictable. If you're doing without a concept, without a background, you need to realize that once you do that, you might have this is my work. You might have a wonderful result like that at the beginning, but then follow your cases up and you will find out that no, it doesn't work. There has to be something else that should be done in order to sustain this result of 2nd July 2013. You need to do something. So I believe that the first method is not really doing very good. We always see problems. We always see post-operative resorption. We always see soft tissue dehiscences. We always see all kinds of things. So I believe that this is void. Mucoperiosteal flap reflection. There are so many authors that introduced whatever types of flaps, buccal, esthetic, preservative, and full mucoprosteal flap. All of these flaps involving vertical incision. And the vertical incisions has been stated in the literature, it is responsible for the worst aesthetic outcome and keloid formation along the wound edges. So you don't get surprised when you see keloid tissues, when you see scar tissue formation along with vertical incision. I'm not sure that this also is a valid solution. I'm not going to mention the other techniques of Dr. Tarnow. He will be happily, of course, discussing this with you very soon. But the socket shield is also another technique that is really emphasizing immediate implant placement. Sometimes they call it partial extraction therapy. The thing is that when you do this, it's a very good technique, but you need to realize that it requires intact buccal wall. If you have bone resorption on the buccal wall, it's nonsense. So you need to have absence of peri-apical infection, no mobility of the shield or no mobility of the tooth, absence of periodontal disease, C-shaped line angle, shield line angle to line angle, create a S-curve for the prosthetic space, remove the apex, all the RCT materials, you have to do that, no fracture or dislodging of the shield while putting the implant. It's a very, very critical procedure, and I don't think it's a very easy to be done. Plus, it needs it needs like a complete intact socket to do. We have seen a lot of errors with this technique. Langer and Nevins also have stated that it entails severe coronal bone loss, retrograde pre-implantitis that was published. And Nevins stated that clinicians should exercise caution when placing dental implants in sites with retained root fragments. The failed implant surfaces were infiltrated by bacteria, deposits, and calculus. So it's a debatable technique as well, and we really need not to go in details with this. And of course, the famous protocol of contour augmentation, which is called early placement. Dr. Daniel Boozer, a great person, a great speaker, a great scientist. I know that he's a friend of Dr. Tarnow. He spent some time at his office last year with the sabbatical, and they work well together. So he categorized immediate placement, early and late, and he just confined the inclusion criteria to immediate placement into a very, very limited selection, which is they have a very thick labial bone, thick soft tissue, no acute infection, good primary stability of the implant, which is almost less than 5% of the cases. What he does is anything else, he does the early placement. That is really well documented in the literature and really very good backup from the literature and reviews, and he's well published with this technique. Well, the technique has a little bit of concerns that it requires multiple surgical intervention, prolonged treatment time. This treatment will take up to 8 months. Original socket dimensions are lost after tooth extractions. Once you extract, you lose it. And the concern is raised from raising mucoprosteal flap. I'm not really sure when you raise a mucoprosteal flap, how would you retain the original soft tissue margins as is post-ruptively? I'm not sure how I can do that. The need to fabricate, of course, long-term provisional restoration for the patients that are going to wait without teeth for a long time. That's what I'm saying. You extract the tooth, you see the drop, and then the drop gets further, and then it heals down, and then you lose the bone. So you move the situation from into this situation. So you need to deal with another defect. Like here, look, this is 0 weeks, this is 4 weeks, and this is 8 weeks. This is our follow-up for the loss of the socket profile. Now I have to come up with a procedure that compensate for all of these type of loss. That's my concern. Also, some cases that we have done early placement for it, this is 0 day, this is 3 weeks, and at 6 weeks time, we lost the papillae. That's another thing. If I personally, I'm not sure about others, but personally, if I lose this papillae, I'm not sure I will be able to regain it back. So that's my thing. On top of that, the vertical incisions. He does the vertical incisions, of course, without even sparing the papillae. So the impairment of the periosteal vascularity is a valuable issue for providing potent blood forming activity, vessel forming activity through the various angiogenetic mechanisms required for the wound healing. So I personally end up with these type of results in doing contour augmentation. So maybe it works very well with Dr. Boozer, of course, but personally, I'm not really comfortable using those early placement things. So what is the question? What might be a logical approach to perform immediate placement with intact or compromised fresh extraction sites? I'll give you some tips and tricks of what to do in order to get this. First of all, it has to be a flapless approach. I believe so. And you need to compensate against the post-extraction labial plate of bone resorption. That's for sure. Because we know that when we extract, no matter what you do, you will lose the labial plate of bone. So I need something that prevents this from happening. Precise implant positioning, not arbitrary anymore. Regenerate all the lost and hard and soft tissues. Eradicate any active infection signs of the socket with no delay. That's something that has to do also with a good procedure and long-term stable aesthetic outcome. That's something that I have to really emphasize, which is I can't really judge a case on a 6-month basis. I can't just judge an outcome on the short-term outcomes, 6 months, 1 year. No, we have to get 1 year and up. That's what the thing that you should measure your cases with, especially with the immediate implant placement. Precise identification of the socket type. What is the socket type that you are dealing with? And it brings me here to the socket types. And we know all that alien Tarnow classifications, one of the best classifications that has been introduced in the literature. And I'm using it every day, and everyone is using it. I'm sure that you do that as well. But I still have the question. I still want to use the procedure, the classification, along with some minor modifications. For example, the thickness of the socket, soft tissue, the thickness of the labial plate of bone, and the available level of the palatal plate of bone. That's something that I would love to add to this classification that would enable us to communicate even more precisely and to describe the best therapeutic approach to such sockets. We have so many sockets, as you can see here, so many sockets in the oral cavity that we really need to cover. As you can see, thick, hard, infected, soft, bone, whatever. And I believe that this is a class 1 socket with 2 very good intact labial plate of bone. But look, we have abundant keratinization here, and we don't have a keratinization here. But these are both class 1 sockets. So we have to distinguish between the 2 sockets by a way or the other. Here is another 2 thin tissue cases, with one of them has bone and the other one has no bone completely. So we really need to distinguish between the sockets on the basis of the legendary classifications for dentists and others, which is class 1, class 2. I've done a little bit of modification that I've published in my previous book. I put into subdivisions to this classifications to have distinguish between the thick, thin tissues, thick, thin bone, presence of the palatal plate of bone or absence of the palatal plate of bone and labial plate of bone as well as the class 3. So this is what we have published recently, just to enable us to communicate and maybe define. If I have a case that is class 1, then we say that, okay, class 1, division 1, what is the soft tissue? What's the bone thickness? Do we have filtration? Do we have the existing labial plate of bone? Do we have the palatal plate of bone that is not there, etc.? So of course, it's liable also to more modifications, but just an attempt to raise the flag that we really need to offer a classification that works well for everyone. Flapless, yes. I believe that a flapless approach is the unique approach, and you will see Dr. Tarnow covering this very nicely. It enhances the post-operative tissue stability, minimizing post-operative recession, bone resorption around immediate implants in dogs with flap reflection exhibited at least twice the buccal bone height loss when compared to the flapless group. That's something that is important as well. And this is another article that is really, really important when they have analyzed the blood vessels on peri-implant mucosa, comparison between the many incision flaps and flaps in dogs. And they found out that there is a tremendous difference, significant difference, that flapless surgical implant placement approach using mini incision provides better vascularization of the mucosa after 3 months of healing following surgery. So this is something that is enlightening as well, and it is covered up by the literature. One more thing, which is, what about the soft tissue? What about the soft tissue that we have here? Do we need, if we have thin cases, if we have thin soft tissue of the socket, do we need to do any intervention? Do we need to enhance the soft tissue? Of course, any procedure that should focus on sockets and immediacy, you should consider using connective tissue graft to cases like this. Could immediate implant placement become a viable treatment option without enhancing the soft tissue phenotype here? I'm not sure. I'm not sure I have the courage to place dental implant in this type of socket. We always need to find out a solution, a way to enhance the soft tissue prior or along with dealing with immediate implant placement. So we might have enhanced contour, we enhance the tissues here, we enhance it here. We have to really find out a way to deal with soft tissue contours. And this is what I come with, what I said before, the Uli Grunder's work. When you really bulk up the labial bulk, when you increase the labial bulk by connective tissue grafts, you minimize the resorption of the labial plated bone, as has been proven by Uli Grunder Uli Grunder at 2011. And you need to use any flapless technique. You cannot do an implant, place it arbitrary. You have to really put the implant along with using a surgical guide. That's something that has to be done for sure. This is the implant placed, leaving the gap, subcrestally sinking the implant, leaving the buccal gap. This is the way we do it. This is not arbitrary placement. This has to be done with. So my advice to you is that do not think that is easy to do when you just put the implant with your hand manually and you think you are an expert. I am being 30 years now doing this profession. I'm failing to put an implant, to do the drill this way. I have to use the surgical guide. One more thing that I know that Dr. Tarnow will cover this as well is sealing the bone graft complex with customized abutment. To seal the bone here, if you put bone inside the socket, you need to isolate this bone from the oral environment. So you always need to use customized healing abutments. And I know that Dr. Tarnow will share with you amazing customized healing abutments that he has done with Dr. Chu in New York. And it's also by the literature that immediate implant restored at the day of the surgery demonstrated more stable mid-facial soft tissue levels and bone volume maintenance than the delayed one. So once you can do it, then you should do it, and you should also preserve the socket architectures along the stages of the healing around the implant thing. Now, question, getting to even a critical question: could immediate implant placement performed in deficient fresh extraction socket with higher degree of predictability and long-term tissue stability? We have to really ask this question. Can we do that? Well, if you see the Tonetti et al. With their workshop in periodontology in 2019, they have stated that immediate implant placement should be avoided when extraction sites were severely damaged that is more than 50% loss of one or more of the walls of the socket. So this is something that has been stated and then confirmed. But I think that I will just enlighten you with some new work that I have conducted with a group of coworkers 2 years ago. I started a new technique that enabled me to treat and to move this type of situation into this type of situation with no vertical incisions, with flapless placement over 10 weeks duration immediately. Same thing with deficient labial plate bone. This is 2 years. This is 2-year follow-up with 10 weeks treatment duration just to get there. Same thing. Complete loss of the labial plate bone, full regeneration of the labial plate bone with flapless approach, no vertical incisions. Same thing here with thickening. You can imagine the thickness of the labial plate bone after 1 year. This is a 1-year follow-up. This is 10 weeks duration. Again, this is pre-op, this is post-op. You can see tissues, margins, all look alike. And this is the type of regeneration that we like. So this is a new protocol. And when we go even further with socket infection, when you have infected socket like this, what would you do with infected socket like this? Most of the studies that I have even searched the literature so many times, I found a lot of systematic reviews that recommended, all of them said it's no problem when you take teeth out, when you have infection, clean well, don't put bone grafts, put implants with or without bone grafts either, and you feel comfortable. All of the results were really okay. And I have seen this in all the literature. But the question here that I'm not sure that any of us is doing this. I'm not sure I can do that. I'm sure that Dennis wouldn't do that. Dr. Tarnow, I'm not sure that he will do that as well. So, because we have risks involved with placing dental implants in infected sites. First, elevated risk of the bone graft infection, the increased risk of implant failure, the flare-up of the patient's condition. But what about if you have not placing implants? We also have problems. We also have loss of socket architecture, risk of interproximal tissue drop, as I showed you before, change of the socket osseous defect into another rather defect to treat difficult, and then the longer the treatment time and the provisional restoration. So that's the problems. It's two things to weigh in your head. But if you had a case like this, what would you do? Partial loss of the labial plate, partial loss of palatal plated bone, and complete loss of the labial plated bone with active signs of infection. What are the options? Now I'm not talking about these sockets. I'm talking about these sockets. If I postpone immediate implant placement, I end up with lost socket architecture, and I really need to get extensive grafting methods. If I extract and wait for some time, I have elevated risk, definitely, of failure of either the bone graft, whatever. So many risks that are involved with both technique. But what if I have a case like this? This is 31 years old young lady with multiple apicalectomy surgeries, like 3 times, lost completely the roots, the root height, with complete loss of the palate of the labial plated bone and active signs of infection. And we get to this result with this type of regeneration in just 10 weeks time with no vertical incisions at 2 years follow-up. Also, thin cases, complete thin tissue with very thin or absent labial plated bone, and move this case forward to this with this type of bone graft. this type of regeneration in just 10 weeks time with 2 years follow-up. 2 central incisors for a lady that's 35 years old with no labial plate of bone, with active infection, and move it here into this abundant labial plate of bone thickness at the same 2-year follow-up period. Well, the same case that I showed you in the beginning when I said that what to do with a case like this, yes, we could reach up to doing this with no vertical incision, with immediacy, with immediate implant placement, with palatal regeneration, labial regeneration in 10 weeks time with no vertical incision at 2 years follow-up. Now, the power of the studies. We have 2 studies now that one of them is accepted, that you will see it next month at the JOMI. The other one is already under review. We have these studies that has evaluated this technique. It's called vestibular socket therapy technique. And we have a lot of parameters to measure with me and my co-workers. And we have the pink aesthetic score that evaluated soft tissue texture, soft tissue color, deficient process, whatever, and the mesial papillae, distal papillae, and we saw all of this together, and we put it on a study. The first study was 6 months. The second one is 1 year, 1 year maybe 2 months, and we measured the labial plate of bone thickness gain. And I will update you with this technique once this article is being published in the JOMI. Follow this up. I think it's going to be in June. It's going to appear in June. So probably it's next month. And I certainly would like to entertain any help or any question or any, you can, escaryimplants.com. Just email me at any time. I'm willing to help at any time, and I would really take this opportunity. I think I have still 10 minutes to go, and I would really thank BioHorizons. Amazing people, amazing opportunity, amazing assistants, Melissa, Ralph, Andre, everybody that has really helped in putting this seminar together. Also, Valleytrade has a hand in Egypt to put this webinar as well. They also had the idea, and I would really thank everyone very much. Thank you all of you for being here with this crowd to watch this presentation. Thank you very much, and you have a pleasant evening. And I'm still here with you, and I would like to introduce Dr. Tarnow. I'm not sure how to introduce Dr. Tarnow the way I like, but if I would like to introduce Dr. Tarnow, I would not take the opportunity to introduce him as written in this papers. I would like to, without any exaggeration, I would like to say I've been known this guy for over 20 years now. He is a man, of course. He is a man of his word. He has supported so many scholars in his life. I'm not really sure if I would like to say he has been the president, the chairman of the implantology and the periodontology department in NYU for some years. He has so many scholars there. He developed the section. He's developed the program. He had so many scholars there. Now he's in Columbia. He's a clinical professor. But I don't think that's what really matters, because no, what really matters is that he is a person who has changed the face of implant dentistry nowadays. He's the one who put a new vision, a new way to look at implant dentistry. And I have seen that he never failed anyone. He has so many scholars. He's still seeing his students every day, all years. He has even Tarnow alumni. I had the pleasure to attend one of those. I have been the pleasure to be one of his students as well. So I'm not sure if you see the wealth of having such a man in this field. I'm not sure if you see the treasure that, I'm not really doing any exaggeration. I'm just saying that this man is an honor to have someone like him in this profession. He put things in the right position. He published so many articles, over 100, even more in the literature. He peer-reviewed so many. He taught so many people. And plus, he served so many patients. He had an elite practice, one of the best practices in New York, with his, of course, group of clinicians working with him and doctors. And I would like you to welcome Dr. Dennis Tarnow for this show. Please, Dennis.
Well, good morning, everybody, or afternoon. Thank you so much, Abdul. It's a wonderful, moment to be on the podium with you. As always, we've done this before over the years, and it's hard to believe it's 20 years. That's amazing. 20 years, and you don't look a day over 15, so this is pretty good.
I think it's more than 20 years. The first time I saw you, I think it's more than 20 years. The first time we met was, I think, in Spain, and it was on the main podium, I think 25, when Ronnie Meffert was there.
Right, many years ago. Well, let's get going, and then we'll have a discussion at the end. I'm looking forward to that. So let me see if I could share my screen. Could you switch over to my slides? Okay. I hope everybody can see that.
Yes,
okay.
Yes, we can see it.
Everybody okay? Okay, good morning or afternoon, everybody, wherever you are. First, I want to wish everybody good health in this crazy times with the virus. I hope, just as we are in New York, consolidated and quiet. I know that most of you are too, and hopefully we'll be able to see each other face to face in the future. But this is a new generation of thinking, a new way of webinars like this. We appreciate BioHorizon and putting this together. I think it's a very special way to keep everybody fresh in ideas. I look forward also to the discussion because I know Dr. Elaskary did not show his actual technique. I know it's not published yet officially, but it looked like he put a pin in with some bone grafting, wedge of bone, and I would like to talk to him about that. I think that would be interesting to be able to place that next high skill level. But what I'm going to do today is try and take the myth out of placement. We're going to talk about some of the things that Abdel talked about quickly already, so I can go over some of it quickly. But let me update you to the present state of the art. Let's make sure that we're all on the same page, talking about the same thing. So what do we know, what we still don't know, and you can see, and what we still have to learn. I think that this is really the key thing. It's always about biology. It's about wound healing, and I think Dr. Elaskary showed that beautifully in his discussion. So I want to get to the point, just like he's doing, is one surgery, one time. It's really we're talking about immediate extraction sockets today, but if you notice, it's really one surgery, one time. The anatomy, as he beautifully showed, is minimally disturbed, and so if you can, we try and do one surgery, one time, wherever possible. I want to give credit to my great team that I'm with. Many of you might know Dr. Chu over here. But all of them, this is a team that I put together over the years in New York with periodontists, prosthodontists, and orthodontists, and just a wonderful group of clinicians and mostly importantly, great people. So the work that I'll show you today were done all by myself surgically and restoratively by many of them, Dr. Chu and Dr. Brown, Dr. Smith, Dr. Zemzak, and Dr. Sanagero. So this is Dr. Fletcher, he's a periodontist, and Dr. Hockman's a periodontist and orthodontist. So we have a whole team of great clinicians, and also work you'll see today. Most of it was done with our master ceramist, Adam. Adam is a magnificent ceramist, as you'll see in his work as we proceed. So I want to give him credit. He's a major part of the team. I'm very proud of this. About 3 months ago, Dr. Chu and I published a book put out by Quintessence. I know Dr. Elaskary has numerous textbooks also by a different group, but this is Quintessence has this. So most of what I'm going to show you today is in this book, The Single Tooth Implant, put out by Quintessence. It's available worldwide. So hopefully you'll enjoy it. I think it really has great details. Dr. Chu and I put a lot of work into it, and it really shows most of the stuff, not all, but most of the stuff that was shows you a lot more than what I'm showing you today. Now, basically, there's three types of sockets. I came up with this really in the year 2000. I presented this concept at the American Academy of Periodontology. We finally published it in 2007. And there's really three socket types. We base it based on the buccal plate. Type 1, other people have different versions of this, but everybody has a type 1 socket, no matter who classification you look at. A type 1 socket is way after you take the tooth out, you have a buccal plate, and you have beautiful tissue over it. So we'll talk about the thickness of the bone in a second. The type 2 is where the buccal plate is partly gone, more than 5 millimeters away from the free gingival margin, and you only have soft tissue as part of the buccal plate, similar to many of the cases that you saw, those difficult cases that Dr. Elaskary showed you. And type 3, very few people get into trouble here with immediates because there's recession on the tooth before you start. The bone and the soft tissue are missing. In other words, there's recession on the tooth before we start. So in the limited time we have today, I'm going to try and go through each one of these to different degrees, give you an overview of where we are. First, let's do what's the easiest cases of type 1s. Nothing is that easy, but to do it right as you store can be difficult. So the facial plate of bone, and I agree with Dr. Elaskary completely, we want to do everything flaplessly. If you get anything, we go everything flapless. Now, when you take out a tooth, you have taken away the PDL. The PDL, the periodontal ligament, is a major source of blood supply to that inside buccal plate, but it's now gone. You have marrow, but do you really? How thick is your buccal plate? Now, as Dr. Elaskary said, they're mostly thin. Very few are very thick. And as you'll see in a minute, it's almost all cortical bone with almost no marrow. Okay. Now, the main thing is the periosteum over the outside. And that periosteum is giving whatever blood supply really to this little thin piece of bone. That's all we have. So the last thing I want to do is lift up that periosteum, if it's there, and start to decrease the blood supply to that piece of bone. A lot of people do that and to put in connective tissues and everything, even if the buccal plate is there. But I really feel that try to minimize that, as you will see. Try to simplify the surgery, especially if the buccal plate is there. Now, if you go back to how thick is your buccal plate, if you look at this work by numerous great clinicians back here, you'll see that what we have here is that if you look at Lindy's work and Bayer, what you're seeing here is that 64%, look at that, 64%, 2/3 of the buccal plates, 1 millimeter up from the crest, is only a 0.5 millimeter. That's in the gold. That's the 6 anterior teeth. Another 23% is 1 millimeter. So just as Abdul said, that what you have here, Abdul said only 10% is over 1 millimeter. 10% of the anteriors. This is human data. So what we see here is that we actually assume that almost all of our anterior teeth have thin buccal plates. And that's why you saw some of the problems that Abdul so well showed you. So they're all thin. Now, this is what confused me quite a bit when I first looked at the data and why I was worried about immediate sockets. This is partly what Abdul showed also with the original research. Lekovic and Kenny did 6 anterior teeth. They opened the flap. And look at the changes in the ridge. Camargo, Ayasella. And you start looking at these results from way back, 1997, 98, 2000. This is what turned me off originally to immediate placement, because of this kind of, the height wasn't so bad. The vertical change in the ridge wasn't so bad height-wise. And why is that? That's because the palatal bone back in here, see, is thicker and holds the ridge up. So that's the key there. So that's what holds the ridge up. But look at this thing. Now this is unacceptable. And I looked at these data and I said, how could I accept putting an immediate implant in and getting 2, 3, 4 millimeters of buccolingual change? And that was the key why everybody said, oh, this is a problem. And you saw some of the side effects. However, when I looked at this, I said, but that isn't what some of my colleagues who were doing immediates were showing. They were showing much better results. And by putting it to the palate, and they didn't see this big problem, a 4 millimeter change. So I went back to this literature, and what did I find? What they did was they opened flaps. And I'm so glad Dr. Elaskary hopped on that. If they open the flap, that's what this research shows. So here it is. How many people know how much bone loss buccolingually dimensional change can we expect? This is dimension of the ridge. What happens if you don't open a flap? So this was all with opening a flap. And it wasn't until really relatively recently, Uli Grundy, who you mentioned, in 2011 was the first person I know that actually measured the buccolingual dimension after an extraction and placing an implant. on the palate, away with the gap, away from the buccal plate, and just watching it for 6 months. Only 1 millimeter. That's completely different than 4 millimeters, 3 millimeters. This is now something you might be able to accept. The key was not opening a flap. No flaps. So I know I can't see you, but I want you all to raise your hand and promise me no more flaps to take your tooth out unless it's impacted. I think Dr. Elaskary both agree on that. No, unless it's impacted, you don't want to do it. Everything should be done through the socket. Minimally invasive surgery is the name of the game, and that's what we are. And Cooper showed the same thing. Baron Cooper, Brownfield, Marco Deghetti, Ernesto Lee, and our work, which I'll show you in a minute. We got down to the ridge dimension changes to be about 1 millimeter or less. This is 1/10 of a millimeter. So the ridge change, if you treat and plan this properly, can be rather minimal. And I'll show you this one case to start off with, a classic case. Now you look at this beautiful woman, high smile line. She's got beautiful tissue and everything, but she's got a problem on this left central. As you see, she's got a big abscess on the palate, and as you see it there, and here's why. You can see the tremendous internal resorption that is perforated. There's not much tooth left, so we're gonna have to take this out. Now this is a tough case. It's thin scallop tissue. It's thin scallop. You can see the probe when you put it underneath the free gingiva. The probe shows through, similar to what Joe Kahn showed, under 1 millimeter of thick tissue. And so what are we gonna do here? Are we gonna let it heal? No, the buccal plate is intact. And we're gonna take it out with minimally invasive procedures. And this is what we're doing. As you see here, take it out. Now, the first thing we do, scalpel incision. Let me take it through. As you see, you can see the probe through. And you take small incisions. In other words, use small incision blades, 15C blades, any surgical blade that's small, so that you don't cut through the buccal tissue when you go around the turn. Advanced surgeons could use a regular 15, but I prefer a 15C. Makes it easier. Take it out cleanly, rotate and out. And there's the big problem on the palate. Now the buccal plate is intact. Now here's the real key, and certainly Abdul showed this rather well, but I want to emphasize this. You cannot slide off that palatal wall. I love the fact that you showed it keeps sliding. You have to start with a sharp dissection burr, and that's the only burr that aims out the buccal, and it perforates about 2/3 up the palatal socket. And once you break through the bundle bone up here, the dense bone here, now you're going to be able to engage all this bone, but you can't go at the same angle. That's the #1 mistake of creating recession down the road. Anything too far forward and too close to the buccal plate that he showed so well. So now we're going to re-angle everything to come out the cingulum, as you see here. Go in that opening and come out the cingulum and aim at the cingulum with your implant, with your 2 millimeter twist. Then you go a little wider and of course place the implant. Now, he mentioned, notice the implant here that we're using in most of these cases, as you see, platform shift, laser lock top. The platform shift laser lock by BioHorizons works beautifully. Now, where do we place it vertically? We place it about at the buccal crest if it's there, or 1 millimeter apical to it. And there's the other key, 1 millimeter apical. That's about 3 millimeters to 4 millimeters below the free gingival margin on the facial. Now, if you do that, how deep is it? Well, you put the implant in here, based on the skull study here, you put it in here, there's a normal scallop of bone in the front of the mouth. Now, the normal scallop of bone is somewhere between 2 to 4 millimeters between the interproximal bone and the midfacial bone. So when you place an implant correctly, based on the labial tissue and the labial buccal plate, about at the buccal plate crest, even though it's to the palate, you're basically 3 millimeters below the interproximal bone, and then there's another 4 or 5 millimeters of soft tissue below the papilla. So you're really 6 to 7, 8 millimeters below the papilla height. You have 4 or 5 millimeters of tissue and another 3 millimeters of bone. So every properly placed implant in the aesthetic zone is what? Subcrestally, interproximally, even if it's at the crest midfacially. So, you think when you look at an x-ray, oh, it looks so deep. No, it's deep, but it's not violating the adjacent bone if it's not too close to the adjacent implant. So all of these implants violate the interdental bone to a certain degree. Now, again, he mentioned what type of implant we use. We use platform shift. This is a laser edge top, the PS, platform shift, and aggressive threads. Now they have the Pro with even more aggressive threads. These are incredible. They really tighten in real well. It gives you great stability in that palatal and apical bone. But you must place it away from the buccal plate. See the gap? That's what I like to see. That's what I want to see. I don't want the, as you mentioned, I don't want it right up against the buccal plate. If you do, there's no blood supply in titanium. So that's going to only sacrifice the blood supply to that buccal plate. and as opposed to a clot, which can reorganize and does reorganize into new bone. Now, this is something else that Dr. Chu came up with. It's called an eye shell, and BioHorizons does sell this for Vulcan, and these are available. And these are preformed like collars that helps keep the tissue from collapsing in and makes it easy to make a custom healing abutment or a temporary. And it goes in like this. Now it keeps the tissue from collapsing. See the opening? Now you can make your temporary. You can add some acrylic. You have your temporary shell made already. And then combine the shell to this and then fill in the voids. Take it out of the mouth. There's the eye shell. There's the opening with the shell attached to it, the outside customized temporary that you had before. You've joined the two together with the peak abutment, and now you just fill in the voids and then round it off. And all that is done outside of the mouth without blood. And that's how we wind up with a nice temporary like that. And so that's the step-by-step concern of how we do this. Now, we're not finished staining this yet, but at least we have the temporary. We take it out of occlusion. No, we don't want any trauma during the healing. So this goes in at usually over 30 Newton centimeters torque. And we filled it up. Now I want to put in some bone grafts. And we'll talk about this a little bit more. I want to fill this up with some bone graft material. Now this buccal plate is here, but I can't get to it. Look at the left screen. I can't get to it because the temporary is in the way. So while this is being stained, I wanted to put a straight healing abutment on, as you see here. Now I can pack the bone. And we use small particle cancellous bone because the chips are great if you have the room for it, but I want something that I can get in there all the way up inside this crevice right in here. So we do use small particle cancellous bone because we're going to do something different. And this is why I don't mind the bone chips up to the crest, but we're going to do something called dual zone socket management. So we put the bone chips in, and we have special instruments. Salvin and other companies make packing instruments. And I'm going to put it in and pack it against this here, and then wait till it clots for about 3 to 4 minutes. Then I slowly take off that straight healing abutment. Now I have the temporary already. And now the temporary has been stained, and I put it back on, and any excess gets squeezed out. And this is socket seal, prosthetic socket seal. Paul Weigel put that term, the wonderful term, prosthetic socket seal. And that holds the graft in place. And now the implants to the palate. I've got a graft in the gap, which we'll talk about that in a minute. The buccal plate is intact, and minimally invasive surgery. Take a look. Beautiful. So the patient walks out that way. Here is what it looks like 2 weeks later. It's as if nothing happened. And that's what we like. Just like Abdul showed. This is 2 weeks later. Now you got to let it heal, let it integrate. Now, the reason why we go dual zone, we're grafting all the way to the height of the free gingiva. Dual zone means up to the bone, in in the gap, but also we're bringing it all the way up. I came up with this about 10 years ago because I had some extra material. I said, let me see what happens if I put it up in the soft tissue. And you know what happened? It thickened the tissue, and the particles will heal inside that free gingiva and thicken it. So I don't always have to go for a connective tissue graft. This is the simplest technique I've come up with great predictability. And this is what it looks like in 2 weeks. There's the implant. Notice it is below the interdental bone, exactly what I was talking about. See, here's the interdental bone. Here's look at the scallop. Normal. That's what we expect. So it's about 3 millimeters below the interdental bone, but it's at about the buccal plate, maybe a millimeter apical. There's a beautiful implant, beautiful platform shift. And look at this at 2 weeks. Here is at 4 months. Notice we hardly lose anything. It looks beautiful. That's what we like to see. That's because we went powderly, and there's plenty of thickness of tissue and bone now on the buccal. Similar to what Abdul said about narrow diameter implants, gives you more room on the buccal. Palatal placement is number one, along with the narrower diameter with good stability. And there's the beautiful tissue, and there's what we see. Now, when we take it off, we sometimes see bleeding, and that's actually good. We published on this. Won't have too much in the short time we have. Won't go through too much of this. But when you see bleeding, that means the epithelium actually adhered to the temporary. Epithelium can adhere to any clean surface. It can adhere to titanium. It can adhere to ceramic. It can adhere to acrylic. And so when you have a fresh piece of acrylic in here, you actually get this bleeding is really the junctional epithelium is on the temporary, and it allows this beautiful tissue to heal. Look at the thickness. So this is what it looks like. The bleeding is actually good the first time you take it off. And then we take a custom abutment, put the abutment on, put some GC pattern resin in to pick it up, do a GMAS laboratory, pause it up with GMAS so they can take this on and off. an aesthetic model. And then this one was cemented on, make a custom post, and here's the final crown in place. Today we do more screw down, because we avoid cement completely. But this is what it looks like. As you see, this is thin scallop tissue. And I think you agree that we have a very nice result, and that's what we see. And here it is 3 years later. So we don't see, and there's the bone, 3 years. And so this is what we tend to see, even on these thin cases. So thin scallop doesn't bother me at all. As long as the buccal plate's present, we're gung-ho with this, and we don't disturb it. We don't disturb the tissue this way, no flaps, and minimally invasive. One surgery, one time. So that's what we tend to do. And we published on this, we call it dual zone therapy. Dr. Chu published that name first, but our main article with this, with the graft, the graft is put in the graft, in the bone graft, but also up in the soft tissue, which the particles, as you'll see in a moment, sometimes get incorporated into it and thickens that free gingiva, gives us that extra thickness of tissue. So this is the main article that I published with the great team, with the Salama and Garber and the Sonic Hieros from Argentina, and of course Steve Chu and Kristen Stappert and so on. So we published this in 2014, and we did 4 different procedures. We did the bone graft, and we did what Uli Grunder did, just put a bone graft in, no provisional, no bone graft, no provisional. I'm sorry, put the implant in to the palate, just let a gap form with blood. Next one is just a provisional, no graft. Third group, put a bone graft in with just a healing abutment. And the fourth group, everything. Implant, bone graft, and a provisional. Everything, bone graft and provisional. And that's the group, that's what I just did, as I showed you in that clinical picture. And that's why we go to this, you'll see why. So we looked at this, let's take group number 1, just the implant. Now, Uli Grunder showed 1 millimeter change when he did this, buccolingually, after 6 months. So this minimum 6 months data, what did we show? We showed a 3 millimeters up, which is about where the top of the implant would be, and what he measured, we had 1.1, almost identical, beautiful, 1.1. And so this was very good. So that's exactly a duplicate of what Uli Grunder was showing in Switzerland. Now, when you do provisional, it's actually a little bit better. It holds the tissue out a little bit better. You don't have to push it out later. It's kind of holding it out. Notice at the height of the implant, about 3 millimeters up, 0.7. When you do a bone graft, about the same, maybe a little bit better, higher up, about the same. But look what happens when we do both the bone graft and the provisional, like what I just showed you in the clinical case. 0.1. That's not 1 milli, that's 0.1. Our averages were that big. I mean, that small. It was that minimum change. It was really quite amazing to us that we saw this change. So it's only a millimeter. All of these are within a millimeter, but it's not 4 millimeters. There's no longer 3. What's the key? Palatal placement of the implant. There's a gap there. We filled the gap, ideally with the bone graft, and this is all different types of bone graft in this particular study. It was not restricted to one type. And dual zone socket management to thicken the tissue, and that's what we saw. So this was really earth-shattering for us, but it shows you evidence base as to what we do and why we do it. So we fill the gap for shape. It does not affect what's up against the implant. I don't have the time to go through that wound healing, but whatever you put into the gap does not affect what's up against the implant. It's the same as if you just set a clot in there. I'll say that again. Whatever was going to form on with a clot in the gap would still take place. The only difference is due to some resorption of that buccal plate, because it's so thin, the tissue is held out in a ridge shape. It's filled in with bone, but the ridge is prevented from collapsing in as much if you put a graft in. And that's what this shows. So dual zone socket management for us is our way we've been doing this. We've been doing it for about 8 or 9 years now. So the thickness of this gingiva right here, remember dual zone, we're grafting inside here. So we did the thickness test, gingival third from the top of the implant, middle third, and the incisal third. And of course, the incisal third is always going to be narrow because it comes to a point. But I want the middle and particularly the gingival third to be as thick as possible, preferably, as you'll see, over 2 millimeters. Now this is group 1, no graft. What do we see? Incisal is only 1.2 millimeters, 1 millimeter up, 2 millimeters up into the free gingiva, 1.8, and at the top of the implant, 2.3, based on our wound healing for 6 months. So this is what we published. We published this back in 2015. Now what happens if we do the other procedures? Number 2, put a temporary on, a little bit better. Number 3, about the same if we just do a graft. But if we do the graft and the temporary, look what happens with the dual zone concept. It holds the particles in, And look at this difference right at the top. Now, the incisal third is always going to be small. Middle gets a little bit bigger, but look at this difference between nothing, 2.3 millimeter thickness of tissue buccal to the implant, versus 3.1. That's an increase of literally 50%. That's amazing, 2 to 3 millimeters. Now, what is this green line here? This green line is 2 millimeters. And why do I have that line? Well, based on Bracco's work and a few others now, you want 2 millimeters of tissue on the front labial to your implant. Otherwise, you start to see the grayness of the metal through. I'm sure you've all seen that problem. So we want at least 2 millimeters of thickness of tissue to prevent that tissue from showing, for the metal from showing through. So look at the extra thickness we got, and that's without a connective tissue graft, and that's important. So we didn't have to do that. Remember, this is a case where the buccal plate was present. That's key. So that's our winner, and so that's what we do on a routine basis. Now, what type of graft material is a big question mark? And we're still working on this. It's really a work in progress for a lot of reasons. Elaskary's talking about chips with the big opening. I don't dispute that, especially if he puts something in front of it. But in the soft tissue zone, I don't want something too thick, not in the soft tissue zone, in the dual zone, because otherwise they kind of become irritated to the tissue. So I want smaller particle size to thicken the tissue, but where the body can get rid of it, as you'll see. So you can use a xenograft, which I don't mind inside the gap, and use an allograft, autograft, it's autogenous, and alloplast, which is synthetic. And most people use one of these bone graft materials. So I want you to look at Philip. This is what we started to see. Take a look. Philip has a broken tooth. He was sent over by his dentist for us to fix him. And what you see here is the crack, as you see here. We're going to take the tooth out. But wait, now I can't take it out, well, wait, what am I going to do? The buccal plate's there, but the tooth was fractured. And how do I get it out without a flap? I don't flap. Everything is through the socket. Now, if that doesn't look big enough for you, that opening is not big enough for you, put some loops on. Then it'll look a lot bigger for you. So, this is what it looks like without loops. This is what it looks like with loops. So put some loops on it. We're going to take everything out through the socket. There is no way that we're going to do open flaps just to get that root out. Everything is through the socket. What I do, there are a lot of ways to do it. I'll just show you my technique. Long, thin diamond burr. Brasilia makes this, 859 surgical length burr, 859 surgical length. It's long. I get this tip right between the tooth and the bone, and I open the ligament space up. And then I go in with these PDL elevators. They're not periotomes, they're elevators. They're very small elevators. It goes into the opening that I create with the burr, and then I get the tooth out. Now, again, I put the implant into the palate, have the temporary made, in this case, Dr. Chu. Okay, I made the temporary, put a straight cylinder on, look at the wide opening. I'm going to put some graft material in now. Now, in this case, we use BioHorizons collagen. Now, that stays around, as you know. It doesn't resorb very easily at all. So I put it in. The collagen part does, but the BioHorizons stays around, as you'll see. So I put it in and packed it. Beautiful contour. Really, look at all the distance now I have. Gorgeous, gorgeous. Very nice. All the thickness. Place it in, let it solidify about 3 to 4 minutes, let it clot a little. Take it out and then put the temporary on. It's already been pre-made out of occlusion. Place it in. This is the way the patient walks out. Put the graft in place and the implant in place. Here's the implant. Okay, the graft's in place. Here it is at 4 months. At 4 months, Steve took the temporary off, ready to take the impression, but look what he saw. This is because the body can't get rid of the xenograft in the free gingiva. It doesn't want to get rid of it. It can't resorb it. It's calcified xenograft. It's sintered, so it's not like regular bone. So what we see here, is the particles there. Now the tissue was thick, but these particles, the good news, it didn't work out the buccal, but it's coming out the sulcus. In fact, see this little spot? See that little spot here? That is the same spot as you see here. You don't see it. It's the same day. It's right there, right there. That's that little spot. It's working its way out. So Steve said, should I take it out? I said, no, leave it alone. He made we kept going. He made again, the cementable one in this case, but he made it customized. We gold plated. This is ceramic metal that's gold plated. That's what we like to do for color. And here it is at 5 months, 6 months, and 8 months. Now we're ready to finish the case with this. Notice the particles are still working their way out. And we cemented this on. We cemented this in and tightened it down, knowing that some of those particles were still slowly working their way out the sulcus. And so that's what we did here and here. And this is the case 9 months later, and you notice it still looks very good. even though those particles are still in there. And so that's what we're seeing here. But it's still got a great result. It's a high smile line, and this is the day of placement of the new crown. There's the pre-op, and there's the post-op. So we can do this very predictably without any other grafting technique when the buccal plate is present. Now, how does this hold up? Here's 3 years later. 3 years later. You see it's there. And this is what it looked like the day of placement. So it's different color from different camera, but this is the day of placement. Oh, it has gone up a hair, but here you see that we have everything intact. So it did kind of hold up, but we don't want that BioHorizons in the supracrestal part of the socket. We want something that the bone can resorb if the body wants to get rid of it, but it can't get rid of the xenograft. And here it is 6 years later. So it can be done, it can be healthy, and here it is 6 years later. So you can see the time does hold up well when you do everything correct. Maybe the tissue went up a hair, but nothing that is visible to the patient, and we're really doing pretty fine. Something which is not the topic for today, I want you to look at something. Let me go back for a second. That's the day of placement. Here's the day, 3 years later. The tissue looks basically pretty good. But look at the incisal edges. Notice that the natural teeth, due to attrition and eruption, came down a bit. They were equal at the time of placement. But 3 years later, and it didn't bother the patient. We didn't even see it. In fact, we didn't see it until we put it on the screen to give this lecture. So you notice that it's just dropped a little, but even at 6 years, it stayed the same. We never adjusted. So that's a separate topic for discussion, but definitely happens with attrition, tooth erupts, and that's part of what we see with changes over time. So the dual zone mineralization, today we use Mineras, which is a very good bone graft material. It's an allograft by BioHorizons, small particle, and that seems to work out quite well. As you see here, it's mineralized cortical cancellous bone, or cancellous bone, and that's what we do. Now, I told you when we see bleeding, look at the difference. That means that the tissue was grabbed onto the temporary. And what you see here is that the vertical height was greater when we saw bleeding and took off for the first time. When we take off that temporary, if we see bleeding, the vertical height was greater than when we didn't. The gingival thickness was greater, middle, and the sizer was all thicker. Look at that. So it actually holds it. So we don't disrupt this until 4 months. Once we put that temp in, we take our time to make a nice temporary. Let that tissue heal and consolidate and mature for a minimum of 3, but ideally 4 months. And so that's what we do. We published this again a few years ago. So one abutment one time is what we all hear about. So keep the tissue attached to the abutment. That's true, but you can't always do that. But I came up with the term one clean abutment the first time, and that may be enough for us to make this happen, and that seems to be okay. So as long as, even if you change it multiple times, the key is the initial healing. Get that tissue to adhere to your acrylic, and then you have to disrupt it to get it off, but it works out pretty well, and that's what we're looking at. Now, what about holding the shape? And I think Dr. Elaskary talked about this nicely. Take a look at this case. We took this bridge off. Again, Dr. Chu was this prosthodontis on this case. He took off this temporary, this the old bridge that was on it. A lot of inflammation, and this tooth was cracked. So I took this tooth out. As you see, everything doesn't look so good. I'm going to put an implant in, and then I made a custom healing abutment. Now, that's before we had the eye shell that we have today. But look what we had to do. See, this collapsed in already. The free gingiva collapses in, as you all know, once you get the tooth out. The implant's in the right position. So what we did, Steve had to make the temporary, so he put the PEEK material on, and notice the free gingiva collapsed in here. And so this is what the eye shell prevents. The eye shell would have been put in there, and this wouldn't have to be collapsed in. This makes more work. The eye shell helps you speed this up. And see the eye shell, now you first take it out, get rid of the blood, and then you fill in the voids, as you see here. Fill in the voids. Then in this case, we're not going to put the temporary on top because it's not necessary in this case. It's just going to put a custom healing abutment on. So I'm going to show this to you. We cut this off. We mark it. We mark the height of the free gingiva, and we cut it off, and this is what we're ready to put in. So here's what the custom healing abutment is that was made. The eye shell will make this much quicker. We put this in. Now, of course, this is a lot of inflamed tissue from the day of the old bridge is coming off. So it's a lot of inflamed tissue. But it holds the tissue out. Of course, we get a little recession because the tissue was so inflamed to begin with. It was not perfectly healthy from the old bridge that the patient came in with. So you see now we held the tissue out. And look at that beautiful tissue. Now this is even without the temporary on it. There's just the bottom half of the temporary. The custom healing abutment should be what you do because now you're ready to make an impression, aren't you? So when you take a tooth out and put an implant in, Graft or no graft, you should at least, with donors the buccal plates, put a custom healing abutment on. That will keep, especially in the aesthetic zone, that'll keep the tissue out, prevent it from collapsing in. Because if you don't, I want you to look right next door to this. Look what happened right next door, where I put on a straight cylinder. Look at that. Which one would you rather have after 4 months? Obviously, this one, where the tissue is ready to be taken impression. This one has to be pushed out. You have to make it temporary, or take the temporary and squeeze it out, blanch the tissue, anesthetize the patient because it's going to be tender, and push the tissue out. It's much more uncomfortable and more time. So if you want to save money, this is put your time for an extra 20 minutes. Even with the eye shell, it's 10 minutes. The bottom half of the temporary. Even if you don't put the whole temporary on, at least put the bottom half in, which is a custom healing abutment. The eye shell really makes a difference. And now you're gonna have to pay the price. That's at least a half-hour visit, at least once, if not twice, to get the shape that you want by pushing it out. So once it's opened, the media extraction, do it right away. And there's the different shells. This is what the eye shells look like, and you can ask the BioHorizons people for this. They're the ones that distribute it. To show you how important it is to capture that, look at the great work of Roberto Crespi in Italy. And this was 2 years ago he published this. It was a 4-year follow-up where in some cases he just put a straight cylinder on and delayed the temporary, and the other ones he put the full temporary on, a custom healing abutment or a temporary. Now, if you take a look at it, this is the facial tissue level, the height. Look at the delayed group, DLI versus immediate loading. Look at this. The delayed group, the height was up 1.3 millimeters in recession. See right here? Only 0.3 if he held it right away. That's a big difference of a millimeter. It's a big time. That's the vertical height. But look at this. This is buccolingual. The bottom part of the graph is buccolingual at 4 years. The delayed group, 2.3 millimeters, whereas the immediate temporization group, like I just showed you, 0.3. 2 millimeters buccolingual change. That's a lot. But you never really quite push it out to the fullest extent. If you let it collapse in, even if it's healthy, then you got to squeeze it out. It takes a lot of time, work, and money at the chair. So this is why an investment of a few extra minutes, 10 extra minutes, you put some flowable composite in around the eye shell, round off the bottom, and then screw it in. It keeps the tissue open for you to let it heal around it. Makes a big difference, even if you're not going to put a full temporary on. So antibiotics we use for 1 week post-surgically, right before. We do mostly right pre-surgically, 1 hour before, and then afterwards, of course, for 1 week. Provisional restoration, non-occlusal loading, no contact. Reline slight buccal version if you have to for steep bites. No toothbrushing side for 5 to 10 days. Use anti-plaque rinses and allow tissue to mature for 4 months just to let it heal and hold that free gingiva. That's part of the trick, not 2 months. So for type 1 sockets, I think we covered everything. We only get a less than a millimeter, really a few tenths of millimeters are average when we do a graft. When we do a graft in the provisional, we see almost no change. Peri-install tissue gain without a connective tissue graft was a 0.5 to 1 millimeter increase in thickness, as I showed you, even without a connective tissue graft. Mimics submergence contour of extracted tooth on the contour of the custom healing abutment. That will let tissue come down if you want it. 1 clean abutment the first time may be more important than the number of disconnections. Angle correction implants increase the incidence of screw retain versus cement retain definitive restoration. So that's something different. That's a different type of implant, which I'm not going to cover today. Now, what you look at here, this is type 2. Let's spend a little time on type 2 and type 3. I just want to give you a little smattering of thinking to show you where we are with this as we're going to the second part of this presentation. Now, type 2, there's no buccal plate, or part of it's missing. But you have bone here, but you don't have part of the buccal plate. Now, in the high smile line, this is very concerning if you have a high smile line, because you're not sure ever where this is going to wind up. With no buccal plate, you're still not sure. So if you have a real high smile line, you have to still be careful. So I came up with the ice cream cone technique, where I put the implant, I took a piece of collagen membrane, and you got to use a thick collagen membrane, one that does not collapse when it gets wet. So it's got to be thick when it gets wet, so it doesn't just collapse on itself. Like BioGuide, you can't use. So you got to have one that's thick. So the BioHorizons has one now that's thicker. Use that, shape it like an upside down ice cream cone. So you put the cone part inside the socket, and you trim the top part to fill the top part of the socket, like you see here. This is old stuff. We place the graft in, and then flip it over. Now this is where all the work is getting done, right in here. because that's going to block this fibrous tissue from penetrating into the graft. This top part that's exposed will disappear within 2 weeks. The salivary enzymes will destroy any collagen membrane within 2 weeks, but it's usually a temporary clot and graft container protector. So it's just there for the first few weeks, and then the few particles might wash out at the top after it disappears, but the main part is still in there, and it's keeping the basic shape, like Scary said, keep the shape. And so here you see a case with a high smile line. I'm not going to do an immediate here because the buccal plate is gone. It looks like I should be able to do one, but the buccal plate is gone. It doesn't mean you can't do it with some, but I don't know where that buccal tissue is going to wind up. This woman had, I could probe this all the way up. Here's the infection. So when I have a high smile line like this, I still live by no buccal plate, but the high smile lines, no buccal plate, no implant. No buccal plate, no implant. Not in the case where you see that gingival margin. Now, if you don't see it, you can play all kinds of games, but still understand that it's a crapshoot. You're just throwing the dice. You have no idea exactly where the height of the tissue will be. And so I'd rather build it up, hold it open, build it up, and then come back and place the implant and add more if I need it in a few months. Keep it simple, silly. That's what I do. And that's how I came up with this. There's the ice cream cone. Even when it gets wet, it has rigidity to it, the membrane. And what we do is I put it in after I've cleaned everything out. I hold it in place and I pack in the bone. The minerals is fine here. And then I flip it over. And notice I push it out. And this is what a lot of people don't realize. You can push the graft out. See, right up in here. Push it out because the bone is gone. So notice it's almost distended out because I will get a little bit of shape in. So I want to almost push it out. And then I use some fibro-resorbable sutures, fibrochromic, and that's all I do. So the only part, the buccal doesn't even need anything to hold it in. It's held in by the pressure of the graft, and it's deep enough inside. You just suture the top if you flip it over, and that's it. This part's going to get destroyed in 2 weeks. It's a temporary protective canopy, and then it fills over by secondary intention. This is the part that's doing the work. The part that's covered stays there for a few months, and that's where your guided bone regeneration will take place. And this is what it looks like. 2 weeks, the membrane's gone or close to it. You see a few particles here and there, but the basic shape is kept. In this case, today I would do a bonded bridge, but in this case we just did a little flipper with no pressure on the ridge. And here it is at 4 months. Now don't rush this. This is where the buccal plate's gone. Don't rush this at 2 months. Give this 4 months to reform the buccal plate. The membrane is in there, covered by the tissue. And in this case, I had enough bone to be able to do a flapless procedure and just do a simple punch and put the implant right in. I'll show you what happens. You don't know what, sometimes you still have to open it up. I'll show you what we do with that. And here's the final case in place. So this is what we did. In this case was a flapless extraction, ice cream cone technique. 4 months later, placed an implant because the CAT scan showed I had enough bone regenerated and the buccal plate was there and I could put it to the palate, and this is what we end up with. Now here's something that I do. I know this is where maybe Dr. Elaskary and I disagree in some areas like this, but most of the time we're 98% of the time we're in the same place. But when I have to graft that buccal, if I have a healed ridge and the buccal is deficient, what do? I do not open the papilla to do mid-buccal augmentation or to place an implant. I'm going to do incisions like this, called papilla-sparing incisions. I don't want to build up the buccal on an area. I don't want to sacrifice the papilla in order to build up the buccal. Because once you lose it, just like Dr. Elaskary showed or said, you can't regenerate it surgically. It's not there unless you do orthodontics, and you don't want to start doing that when you had the papilla to begin with. Every time you open it up, you lose more bone. So it looks like this. You can go real wide. You can do big grafts. If it's there, leave it there. Leave the papilla there. Do not disturb sign. So if it's healthy, as it is here, leave it alone. And Gomez-Roman did the classic article on this in 2001, where he did papilla sparing incisions like here, and he did full papilla opening here. And what did he show? He showed that a crown placement, certain amount of bone loss after the extraction, but 1 year later, look, very minimal bone loss on the adjacent teeth, 0.2, 1/10 of a millimeter, nothing serious. But look here, 0.7 of a millimeter, and it went up to 2 millimeters. Look at the range when you open a flap, open a papilla without a papilla sparing incision. Papilla sparing incision, minimal change. You open it up, instead of 0.1 or 0.2, you're down to an average 0.7 with a range of 0 to 2 millimeters. And that's going to give you a black triangle. So we try to preserve that papilla if it's there and try not to touch it. So what happens in a case like this where I have a healed ridge? It's not an immediate, or it could be an extraction. This is a congenitally missing tooth where the orthodontist pulled it open and had a bonded bridge to hold it while he was growing. So now he's finished growing, ready to get an implant in there. Now, how do I approach this? I don't want to touch these papilla, but how do I get the implant in? I do papilla sparing incision, and he's got a bit of a depression here too. So I'm gonna have to build it up. See the darkness here? He's got a bit of a depression. Now, I don't want to open this up and cause recession here. I will tell you that 65% of the patients I treat today are redo of other people's work, just like Dr. Elaskary is showing. And that's exactly why we try to minimize our own problems, and the papilla is a major problem if it creates it. Mid-facial, you can rebuild, as long as the height's there. So here's the depression, as you see now. Now this is what a papilla sparing incision looks like. Now, it's not really, I know he talked about a keloid, but it's really not a scar, it's a depression. And it's a really depression. Gingiva does not scar. If you do a gingivectomy on me today, and it came back to your office in 2 months, do you see any scar? No, because there's no elastic fibers in gingiva. You see a scar in the mucosa, you see a scar on skin, but on gingiva, you don't see a scar. So it's really about how well you adapt this tissue, and you might get a little depression in, but it can be easily plastied off. It's a groove more than a scar. So you see the incision. This is what a good papilla sparing incision looks like. That's not going to go anywhere. It's not being touched. Papilla sparing, and it carried around to the palate. Think about 1.5 millimeter tissue on each side. That's what you see here. Release the flap. Periosteal release. That's mandatory for all grafting. That's the key. Got that done. Place the implant in. In this case, it's too thin here. We're going to build it up. Went to the palate. I placed the graft in and a membrane over it. Here's the graft. There's the membrane over it, and that's what we do. And now I can pull this over, suture it over, as you see here. Stage 1, stage 2, again, one surgery, one time on this healed ridge. And now I leave the papilla intact. Nothing's going to happen to it because I haven't done anything to it. We replace the bonded bridge, retack it. There's the implant placement, nice and clean. And here you see, now you do see the groove here, see? Initially, you're going to see that, but it tends to blend in. If it doesn't blend in enough, like here, it's almost gone already. And here, it's still a little bit of a groove, but it's a groove. And so we put on a straight healing abutment is the key. We go back for a second. When you do this, put on the straightest healing abutment you have. Don't put a temporary on it, or else it'll push this tissue out. Then this keloid that he calls it, it's really not a keloid, the groove gets bigger. So the key here is when you have a healed ridge, do not put a full temporary on that tooth. Put a straight healing abutment for whatever company you're using. That way you can get good closure here and minimize the opening in this groove. Otherwise, because you can't pull that tight, you can suture as much as you want, but if you push that tissue out too far, it won't adapt. So here it is after healing. Now Steve's going to start sculpting the tissue because this is a healed ridge. That's the sacrifice of not putting on a temporary at the time of surgery. Put on a healed ridge. So on a healed ridge, papilla sparing incision, straight healing abutment, then come back after you've uncovered it, if you didn't do it together, and do it, then stretch the tissue. After 4 weeks, you start stretching the tissue with your temporary. There's the blanching, so it's still healing. There's the blanching, we stain it. There you see it. Groove's still here in this case. Let's see what happens to it. And there's the slight groove. See, that's not really, see the groove? Now, if you really have a patient that's bothered by it, and most of them are not, but if you do, I've only had one patient I ever had to do that in all the hundreds and hundreds of implants that I did this way. You can just take a dermabrasion like a round diamond, a quartz round diamond, and plastic it flat. Plastic it flat if it bothers the patient. No, but that's all. There's no scar, and it comes in without a scar because it's not a scar. It's really just a little depression. And there's now to make the final crown. And here it is, 1 year recall. Here it is at 6 years. Nothing was ever done to that so-called scar. 6 years later. There you see a close-up, and you're sitting real close. Now, this is more than adequate, I think, in terms of what we need on thin tissue that was built up with some bone graft, placed to the palate, vertical incisions, and this is what we see. Beautiful tissue height. The key is going to the palate and coming out the cingulum. Screw down, and this is where we are today. So that's for the type 2 protocol. That's what we do. Now, where do we push the system? And obviously, Dr. Elaskary is pushing the system with his new graft technique, which I look forward to seeing. But he's probably putting a graft in because there's notice pins in there. So he's putting probably a piece of bone in, I assume. We'll talk about it during the discussion. But he's got to make a little hole, probably to suture in it, to bond it in. That's minor. It's not a full flap. I don't mind that, but it means extra work. But here's another technique for certain cases. And that is to combine the type 1 procedure that I showed you with the type 2 procedure with the membrane. And what do we do here? This is Guido Sanacchiaro, one of my partners, came up with this combination. He said, biologically, this makes sense, Dan. And he did this in non-aesthetic zone cases. I repeat, he did it not where the tissue shows. This is where the buccal plate's missing, but the tissue is not, the smile line was low. So that's rather important. But what he's going to do here, he's going to the buccal plate's gone. So this was mostly bicuspids, and this is what we've been doing now. So we flapless extraction. He did 10 cases in bicuspids. We published on this in 2015 now. You got primary stability going to the palatal root and up in the apical area. So we got good stability with a BioHorizon type of implant. Custom healing abutment. See, he made, instead of a full temporary, he made a custom healing abutment. Although now we can make a temporary too. We weren't sure at the time. But this is like the top part of the ice cream cone, but you don't need it now. You're going to make an acrylic temporary to keep the tissue open, like the eye shell. You take it off, put a membrane in, then put a graft in inside. So now here's your GBR. There's your, that's like the cone part of the ice cream cone combined with the bone graft in. So you graft the apical part, and then you have the custom healing abutment. You put the custom healing abutment back on, and it socket seals the surgery, and it keeps the shape of the tissue open, and allows you to graft that whole buccal area that you do later. And that's the combination of type 1 and type 2 ice cream cone combined with type 1 surgery. And here's what it looks like, even with an infected buccal plate, as you see here with an abscess. Took the tooth out, cleaned it out thoroughly. You must debride it. It's just like Dr. Elaskary said, you go in, you clean, and you debride it. Now, implant, look at the gap distance. Beautiful. Because this is particularly bicuspids. So this puts into the palatal root, still comes out the central fossa. Then you put the membrane in. This is the bottom half of the ice cream cone. You don't need the top half. That's going to be a custom healing abutment's going to go over there. So you put that in, pack the graft in around it, and then put the custom healing abutment back on. And this is what it looks like after healing. Custom healing abutment held everything in. This one we give 6 months because it was so bad. So in 6 months we take it off. Look what we see. Beautiful, beautiful sculpted sulcus. Look at the tissue shape that was completely gone. And here's the final crown in place. And look at the buccal. What you see here, because there were bicuspids, we had big gaps. And we developed this big gap. As you said, we developed a big gap because the buccal, this was in the palatal root. So look at this distance here. We started with nothing. And what he did in the research that we published, that he started with 0 buccal plate. And what you see here is that he started after we did a CAT scan right afterwards and got 3.6 millimeters. That's really old graft material. That's really old graft material. Then at 6 months, we took another CAT scan and we realized we only lost about 0.6 of a millimeter, about half a millimeter. So we had 3 millimeters of what appeared to be buccal plate combined with graft, really graft with new bone. And that's what when we sound it, it feels like bone. This is 6 months later. And so we gained 3 millimeters of new buccal bone. And so that's particularly by cuspids, that's pretty easy. And then as we start pushing the system, here's Wendy. Now, Wendy does not have a high smile line. She has a moderate smile line. But she's a high-level, high-profile patient, travels all over the world with her husband, very wealthy, and she just comes in and she fractured a tooth. So Steve said, should we try this lateral fracture? So, this is against all my principles, but it's not a totally high smile line. And I discussed it with her. I said, listen, we have some new technique that we're doing that we might be able to get an implant in and put a temporary on the same day so you don't have to walk around with a flipper or an Essex retainer. And she said, but it might allow recession, but you may not show it. So she knew that, and I put it in writing. Look at the buccal plate. There's the crack, classic crack. We're going to take it out. There's the fracture. Clean it out thoroughly. Place the implant. Look at the gap distance. Beautiful. Place the implant in. Here's the eye shell. Put some acrylic in there. Then put the temporary on top of that. So this keeps the tissue open. Okay. Then Steve's going to make the temporary, as you see here. And there's the graft. Now we put a straight cylinder on, and we're going to pack the buccal. And here's the membrane being trimmed. Here's one of the tricks with these stiffer membranes. I trimmed it and then put it in. And when I took it out, what did I see? I knew exactly where the height of the tissue was by the blood. So I'm going to trim this back right up to that point. Trim it back. And that's exactly the height of the tissue. I'm going to place it back in, and there's the gap, and I'm going to fill it with bone, with a straight cylinder in there, straight healing abutment. Here you see the graft being placed, pressed up, and you hold this in place, so moving in. Here's you see the new graft, and then slowly take it out. Now you have the temporary made, you're going to squeeze it on, and you're going to push all this bone out and distend it up. And that's what I did here, as you see. This is pretty bad shape. This is a big wide open ridge. There's the implant in place. Notice we had 2.2 millimeters of graft in there, which that went powdery. And here it is in 1 week. We didn't lose hardly anything at 1 week. Okay, still a little inflamed, of course. It's only 1 week later. She had a big abscess here. Here it is at 6 months. So we got something that worked with the temporary in place. She was thrilled. She's sent other people to us. That was not perfect, but the lateral was normally depressed anyway a little bit compared to the centrals. As you know, it's a little more powder. But this is more than enough tissue to do what we need. You take it off, look at that extra tissue. The graft is in there, everything looks good. And then Steve made the final crown, it's gold plated, ceramic metal, screwed down, right down to the implant. And here's the final crown in place at 6 months after the grafting. Here you see it, and we have a pretty good result for 1 stage, 1 surgery, 1 time. The tissue's covering it, not bad thickness, and we're in pretty good shape. There's the bone grafts, that's at 6 months later. You see the bone is still in there. That's good. And here is the 3 years. She doesn't have great hygiene, but 3 years later, we're maintaining this well. And here's the pre-op. This is what she came in with, the fractured tooth. Minimally invasive surgery, a happy patient, and that makes us happy because when she's happy. But she had a low smile on. This is a high-risk patient. She had a low smile on, and I explained to her that we can't be sure what height the tissue will be, but she had thick enough tissue to try it, even though most of the buccal plate was missing. So conclusions for type 2, flapless tooth removal, get implant primary stability in the apex and the palate. Use the cone part of the ice cream cone with a GBR membrane. Type 2, you're really making a type 2 defect into a type 1. You're rebuilding the buccal plate. Place the bone graft between the membrane and the implant. Put a custom healing abutment or a provisional. It contains and protects the graft. Kind of graft containment. Socket seal. Prosthetic socket seal. Allows the site to heal and mature for at least 6 months, not 3 months or 4 months. You got to live that time. Now let's spend just a little bit of time before we finish up on type 3s. They're the most difficult in some cases because there's no tissue and there's no buccal plate. That's a case I did in school, but it's a very good example of what we do today with type 3s. This case was not an aesthetic case, but it was in front of the mouth, but it had a low smile line. But I want to show you the wound healing of what we do. For type 3s, we do not do all the surgery at once. It's the one place where we don't do that, even in lower smile lines. We're going to let nature do some grafting for us. Mother Nature's connective tissue graft and bone graft. Now you see, if I tried to do everything at once, even though he has a low smile line, I'd have to bring the mucosa down. I'd have to pull the flap down. I could do it, and many clinicians would do it. But I think in a low smile line, you do that. But then you got to push the mucosa up, and you lose all this chance of getting beautiful tissue in here. So this guy's walking around like this. What I'm going to do is take it out. Now, this is the key. The palatal tissue is still there, even though the buckle is gone. See that palatal tissue and some bone. This is beautiful. That's the height that you're going to reach. Mother Nature is going to fill this in with beautiful keratinized tissue, not mucosa. Watch it. Here it is at 2 weeks. And here it is at 10 weeks. Now you have just a normal healed ridge with plenty of tissue. Now you still have to graft. There's still going to be a buccal defect there. But now look at all that beautiful, colored, nice, keratinized tissue. So let nature help you with it. Don't be in such a rush all the time. So even though we like one surgery one time, now we can do the surgery, open it up, the filler sparing, although it wasn't necessary here. There's the buccal deficiency. Some of the bone filled in 2 months, took me waiting 2.5 months apically. Now I got a predictable implant locked in, release the flap, put a membrane in, I suture it in. Here's one of the techniques sometimes I'll do. I'll put a piece of alloderm in, suture it to the palate. A piece of dermis can act as a membrane. I suture it into the palate with a resorbable suture. I then flip it open. Here it is sutured in. I flip it open as you see here. Now use that as a membrane and it's stabilized by the palatal tissue. Now I'm going to graft over the buccal. And then put my graft in. In this case, you can use whichever graft you want. Mineros is fine, or bovine bone, either one. Then flip this over. It's sitting down here. Flip the membrane up. It's already been released the flap already. And then primary closure. So this is what we do with these kind of cases. We made a type 3 into a type 2, a healed ridge, and then we opened it up and did the grafting. And Mother Nature gave us a beautiful connective tissue graft. And lastly, I just want to show you Alexa's case. I published this with Dr. Chu. This was relatively recently, well, two years ago now. You take a look, and here's Alexa. Now, this is Alexa. She has a low smile line. Notice the difference in the height of the edges. What she came in for, she couldn't stand the fact that this tooth was ankylosed. She didn't know that term, but it wasn't moving, and this tooth was much longer. So it bothered her. She's a nice young woman. And here you see the difference. So this was her chief complaint, was that this was not coming down, and there's a reason. You see the resorption taking place internally, and then perforated through was ankylosed. So what bothered her was not the gingival heights. It's interesting. The gingival height was not a problem. She didn't show it. Remember? She didn't show it. She said, I don't even know. I don't even look at that. I look at the incisor ledge, she said. I said, well, what if I don't bring this tissue down? I might be able to put an implant in the same day, and we can level this off. That's easy with the new temporary and the new crown. Would you mind if the final case has the tissue 2 millimeters higher than this side? She says, not at all. I never bother with it. I don't look at it. I don't see it. And I put in writing that I had that discussion, because sometimes patients later on become very picky after so that's was it. So I said, okay, let's try it. So I cleaned it out. There's the perforation and the ankylosis. Took it out, cleaned it up, put the implant into the palate. Look at the difference in the height. Now what's going to happen here? But they got palatal tissue, and you got the proximal tissue. And so we got rid of the implant, and we got rid of the tooth. That's the key. You got palatal tissue and you got papilla height. And that combination lets tissue come down and we'll form a new ridge. So we're going to put the eye shell in. We'll make it easier. We're going to I put the implant into the palate, as you see here. Facial restorative on the contour. We're going to let this come down. As Rice Gold Short told us, let that tissue get under contour. So Steve made a flat profile temporary. Here it is starting to make it. And then we packed the graft in after he made the temporary. Dual zone grafting is still done. But we're going to under contour this. Here's the temporary. Look how flat that is up here. That will allow this no over contour here. Here we want the tissue to come down. According to, as you know, Weisgold told us that on teeth. Under contour lets tissue come down. Over contour, tissue moves up. So we're going to let it come down. This tissue was thick enough to leave it that way. It's going to come down, nice thick band of tissue up here. So we're going to let it come down. There it is. Watch what happens. Restorative under contour. Here it is in 1 week. Starting to come down. Beautiful. It's only 1 week difference. Here it is in 5 months. It's equal in height. Beautiful. So let nature, knowing what tissue can do, what biology can do, let nature help you. And there you see the result of this beautiful result on Alexa. Take it off, and you see the beautiful extra thick tissue we had under contour. The tissue came down. Then we take an impression. Here's the implant with the gold-plated ceramic metal. Adam does his thing, technician. And this, no grafting was ever done here to the pre-gingival. It came down on its own. And here you see the tissue. We got a nice result. And here you see she never showed that, but that's more for our head. We got the incisal edges, of course, at the right height. And we got this tissue down just by letting nature under contour the restoration. And she's ecstatic, and she never walked around without a tooth. And there's the implant, platform shift, all the stuff we spoke about. And here's the pre-treatment to show you how much movement we got just by understanding biology. Here's the post-treatment. Nice. We got a nice case. So type 3 cases, flapless tooth extraction, let it heal, implant, or if you do just 1 or 2 millimeters like you did there, and it's not a high lip line, implant placement in correct intra-arch position with the palatal bias and primary stability. Existing tooth position is the diagnostic key. If it's too far forward, it will tend to fill in on the buccal. Dual zone socket management, restorative under contour, clinical management is okay. For 1 or 2 millimeters, we get this to come down like you saw here. And if the tissue on top is thick, if it's not, then we do connective tissue grafting like you saw before. So to summate this, immediate implant in the aesthetic zone, type 1, we do it. Whether it be thick, flat, or thin scalloped, yes, yes, yes. If the buccal plate is there in a type 1 defect, which is what it is, we do immediates almost all of the time with fewest exception. Type 2, we don't do it in the highest smile lines, which thank goodness is only about 20% of our cases show the buccal tissue. Yes, for low smile lines. And for type 3, no immediates, let it heal, then come back and do a healed ridge. except for rare circumstances like I showed you with low smile lines. So really, this is the kind of summation. Type 1s, go ahead, gung-ho. Type 2s, much more questionable, especially with the highest smile lines, because you're never sure exactly where that tissue will wind up. But you see, by grafting the gap, we keep the tissue out, and I showed you evidence-based approach to everything that we did, step by step, research, thickness of tissue. It shows you everything with 4 to 6 year data. So we always have to think biologically. All my students know that that's the only way that they can walk into my room and to school. If you're not thinking biologically, then you're not thinking, okay? Because otherwise, then you're a mechanic, and you have to be a great mechanic. You got to be a great carpenter, but always we're dentists. We have a DDS after our name, Doctor of Dental Surgery. That means we think biologically. And do not disturb if something is there. Minimally invasive surgery is the name of the game, and that's what we do. And one surgery, one time, wherever possible. Is it always possible? No, but it is often possible, 90+% of the time. We can do one surgery one time. And I'm glad Dr. Elaskary showed the molars. That wasn't my topic today, but we do it routinely in the molars. We published on 300 cases. There's no question that we have a 97% success rate in our office over 3 to 5 years with these wide body implants. So these definitely are working, and that's a major, major thing you should look at. BioHorizons implant is excellent for that. Good wide body, good threads, just like Dr. Elaskary showed. And again, this is the quintessence book, quintpub.com. You can get that online, and we're very proud of that. And all of the things I showed and a lot more are in this book on the single tooth implant. It shows a lot more cases and more detail that you can go over if you want to. So I want to thank BioHorizon and Dr. Elaskary for being a colleague and a great friend and a magnificent clinician all these years. And so I want to thank you, and I look forward to having the discussion with your questions that I know you were putting down. So now we'll have the question and answer discussion. Thank you so much.
Thank you so much, Dr. Tarnow. We're going to bring back Dr. Elaskary so we can go ahead and take some questions.
Sure.
We have a lot of questions.
I'm sorry, I'm out of time. I got to stop.
No, it's okay. We have 30 minutes.
No, I'm just teasing you.
We have 30 minutes and we have a lot of questions. So,
okay.
Dr. Elaskary, are you there?
Share your screen.
During this session, I'm gonna read the question, and
very good, Dennis. Very good. Very good.
Same to you.
Thank you. All right, let's go straight to the questions. We have limited time, and I want to answer as many questions as possible. I'm gonna go ahead and apologize because some names I'm gonna pronounce wrong, but I'm gonna try my best. Okay. So for Dr. Saptarshi, he's asking Dr. Elaskary, can we enhance a thin soft tissue phenotype with PRF membranes, or a connective tissue grafting is mandatory?
Wonderful question. And I think that I apologize to say that I'm not a big fan of using the PRF. I know that PRF is being widely popular, but it's only an enhancer, as to my opinion, and to some references also that has published that. I believe it's only a healing enhancer. I don't think that it could it has to do anything with bone or soft tissue building. That's my idea, my humble idea, and I believe that we have to stick to connective tissue.
Can I comment?
Yeah,
on
absolutely.
It? Absolutely. I 100% agree with you. It enhances the initial healing, and there's no question that it's growth factors. So it's bringing growth factors in, but it does not act as a full membrane that stays there. It will disappear quickly. In fact, its benefits of bringing growth factors will make the tissue look a little better at the 1 to 2 week post-op. But here's the key: at 3 months to 6 months, which is what you're certainly, or beyond, which is what you're doing all your implants for and all your grafting, there is no data that shows it's any different than if you did nothing. So it's not that you shouldn't use it, but you shouldn't have to go out of your way to harvest the blood, put it in there. It'll help if you're doing IVs, if you're doing intravenous work, go ahead and do it if you want to. But to go and deliberately get that just by doing an IV just to get that, I think it's overkill. We did work on PRP and we showed bilateral sinuses, and there was no difference in there. There was some little in the PRF at the earliest stages of healing. But when you get to 6 to 8 months, there was no difference, zero, as if you did nothing. So it might speed up a little bit of the initial healing, but that's it. So you definitely need connective tissue and or some other material to hold the tissue out. I agree with Dr. Elaskary completely.
Yeah.
Awesome. Thank you so much. We have another question for Dr. Abdelsalam. Can you explain briefly the concept of vestibular fresh extraction socket therapy?
Yeah, well, it's a new complete set of a concept to allow immediate implants to be placed in sockets, either compromised or infected. It's a new set, it's a new protocol that has been published, and it's been studied over 1.5 years now. And it's a simple, not simple, but it's a little bit technique sensitive procedure that is called vestibular socket therapy. It enhances the socket environment through the vestibular area, not through the crestal area.
Okay, and I think we have another question about that. Someone was asking, how do you get that pin? Because you showed a picture with a tack or a screw in there without a flap. Can you kind of touch base on that a little bit?
Yes, through the vestibular area, we use the famous BioHorizons Autotack kit. It's called Autotack kit. One of the best inventions that I I really like. It's one of the BioHorizons products. It's called Autotack kit. How do I get into there? It's through the vestibular.
Okay.
So in other words, you make an incision higher up in the mucosa.
Yes.
Right. And do you do a wedge of bone? Take a wedge of bone?
No, I don't do any wedges. I do I use a certain shield. It's not a membrane, it's not a collagen. I use something called bone shield, flexible bone shield. We have 5 choices for these shields. It's a slow resorbing shield. It's over 1 year to resorb, and that's how we kept. That's how we counteract the resorption that occurs on the labial plate bone, and we keep the socket environment as is.
Right. So it's an allograft. It's a piece of it's an allograft.
No, the shield can be 3 things. It's either an allograft flexible sheet. It's called laminar bone sheet, or a xenograft flexible sheet, or it's something. It's like a polyacrylic acid sheet from Sonic Weld. So it's either or. So we have 3 or 4 choices that we could use. Now we are controlling the thickness of the shield itself. And
the laminar bone, the lamellar bone, has been around for many, many years. I know we used to use it over sinus scratch.
You remember the laminar bone sheet from City Coast Tissue Bank? Yep.
We've both been around long enough.
Yeah, we've been there.
Great. What's the next question, Rob?
I wasn't there, so I'm glad you guys know about that. All right, Dr. Tarnow, we have a question for you. It's asking, do you prefer non-resorbable sutures in immediate implant procedures?
No, everything is resorbable. Almost everything is fibrochromic is what I do almost routinely. And especially in the mucosa, I do it. I don't want to have to go back and start pulling sutures out. So for the procedures I did today, all of them were resorbable sutures, fibrochromic sutures. What my main one is small needles.
Okay. Thank you. We have Dr. Mauricio. He's asking also, Dr. Tarnow, what antibiotic doses do you pre-medicate?
Yeah, same as for heart medicine, 1 dose before is the most critical. But if I'm going to do a graft, certainly if it's infected, like some of the cases that Dr. Elaskary showed, or some of the cases at the end I showed the last half, those patients are on antibiotics as soon as you see them. They got to get the infection down. You put them on antibiotics as much time as you can before you have to intervene. But the key with any surgery is the blood level during the surgery. That's even in a healed ridge. It's the only antibiotic dose that has made a significant difference in percentage of success. You want 1 large dose before, at least 1,000 milligrams of like amoxicillin, preferably even 2, especially if they're infected, do it before. But if they're not infected in a healed ridge, the only thing that matters, if you're not going to graft like a healed ridge, then just go ahead and do 1 dose and that's it. No other antibiotics unless the person has a medical problem, severe diabetic or something. But otherwise, we do one dose. Now, if we do grafting, like sinus graft or ridge augmentations, like the kind of work that you saw with the vestibular surgery that Dr. Elaskary did, or what I was doing when I was doing bone grafting, or when I do the gap, when I do the dual zone, I am definitely giving the patient 1 week of antibiotics afterwards. The reason why the graft is the antibiotic is so important before the day that, not the day, but that an hour before, is that then you get a blood level to be high during the surgery. And people say, oh, I like to add, some people, older guys used to put tetracycline and mix it into the graft. That's not necessary, because you see the antibiotic, once it's in the blood and you put the graft in, wherever it is, sinus, or whether it be in the ridge or a gap, the blood has the antibiotic. Yeah. So you're actually delivering it with the blood. And that's what the key is most important. That's the only surgery, I mean, it's the only time that's considered statistically different in the literature is pre-op, right at the time of surgery. Everything afterwards, or long before, means almost nothing. But those at the time of surgery. And that's true of medical doctors too. That's true of medical procedures too. Massachusetts Mass General, Massachusetts Hospital, did a study of all their emergency patients in the operating room, and they showed that the only antibiotic that stopped infection or decreased the chance of infection was the dose of the antibiotic during the surgery, right before and during. Mm-hmm.
Okay, thank you so much. Dr. Elaskary, do you have anything to add to that, or?
I agree 100% to Dr. Tarnow. The only thing I'm not sure that I have used with those infected sockets is an antibiotic that is a combination antibiotic between metronidazole and ciprofloxacin. It's a combination. Yeah, it's a combination antibiotic.
Sure.
Yeah.
When you have a bad infection, that's right. I agree completely.
Bacteria. Yeah.
When you have a bad infection, you're not sure what you're dealing with, and you can do a combo. Sure. The key is just to get it in before you start your surgery.
Okay, sounds good. Thank you. Dr. Rasha is asking, first of all, she's saying great presentation, Dr. Elaskary, and I'm going to take this opportunity to say that there's so many good questions here. So it's very hard to choose which questions to go with first, since we only have 20 minutes left. But Dr. Rasha is asking, when do you load your immediate implant?
He's asking me?
Yes.
Yeah. Loading the implant is something that has to do not with the technique. Loading the implant has to do with the quality of bone, the primary stability, other issues. This is something that has to be confirmed with the clinician himself. Immediate implant loading is something that has to do with your decision, several occlusion, many things that you have to consider in doing this. There's no special recipe that tells you this has to be done immediately loaded or not, but it has to do with what you really decide upon each case individually. If Dennis would like to add to this, I think you would.
I think it's all about immediate torque in the bite. I think if you get over 30 Newton centimeters resistance torque when you put it in with these screw-shaped implants that we do and tapered implants, we usually find we get out of occlusion. So the word occlusion is temporization, out of occlusion. It's not in contact in centric, and it's not in contact in protrusive. And that's really the key. So if you have 30 Newton centimeters torque when you put it in or above, which we usually do, if we have to be soft bone, we might undersize the apical area where we can engage the bone better, self-tap it in. We always drill to the full length, so we know the path is open. But the width, if we feel mushy bone, we're not going to drill to the final drill. We're going to go one drill below and then self-tap the implant in. And that's usually what we do with softer bone in general. You agree, Abdel?
Yeah.
Under prepare when you have soft bone, and I call it the 2 millimeter twist drill decision. When you go in with your 2 millimeter twist, every company has one, a 1.8 to 2.2. Everybody's got that first 2 millimeter twist drill. When you go in, that's the full length you go in of the distance. And you always make sure the path is open. So you make sure you got your length. But then the width, how far you open it up, depends on the softness of the bone.
100%.
Okay.
Great. Thank you so much. We have Dr. Grady asking Dr. Tarnow, do you condense or compact your bone graft?
Yeah, when I'm doing the type 2, when I'm doing my ice cream cone, I mentioned I definitely condense it well, because now I have the buccal plates missing. I can distend the tissue out a little bit with the membrane and the graft. I push it out, and that's what people sometimes don't do. push it out, and thereby you can definitely distend the tissue out, because you do get about a 0.5 millimeter, 1 millimeter in, because the graft is going to be resorbed a little, but the membrane is going to resorb too. So I like to push it out, and so I'll wind up with a bone. We published on that, Jocelyn Tan, T-A-N is the first author on that, and we get about 1 millimeter change on the ice cream cone technique. It's been published. But the key is to push it out, and then packing it firmly is fine. Remember that the particles get pushed around anyway. When the blood vessels come in from the bone on the side, the particles get tossed and turned, and how well you pack them doesn't matter. It really is irrelevant. But I do want it to push the tissue out. Okay, so we pack it fairly, not firmly, but firm enough.
Okay, thank you so much. We have Dr. Vafa asking Dr. Elaskary. My question is, how can you use a tack or screw without vertical incision in your technique?
Yes, that's a clever question, and I would really thank you for this wonderful question. If you position your incision up high in the vestibular area, you need to realize that the vestibular tissues are elastic, so you can move it wherever you want, and then you can position your tack wherever you want. Thank you for your question.
Thank you for your answer. Also, we have a question for Dr. Tarnow. Dr. Ahmed is asking, in type 2 sockets, when should we use the inverted cone technique alone without placing an implant, or use the dual zone therapeutic concept with implant placement and temporization?
Right. The key is the smile line. I know I rushed through that. If I have a high smile line where the buccal tissue shows, I would do the regular standard ice cream cone, come back in 4 months and place an implant, and add any more bone at the time if I have to on a healed ridge with papilla sparing technique. If on the other hand, the plan is low and the buccal plate's missing, that's when I can get stability. I'll do the combination where I'll do the membrane, the implant, and the temporary. That is where the buccal plate, the buccal tissue is not showing on a patient where they smile. And that's about 75% of our patients. 25%, no way I'm going to do it. No buccal plate, no high smile line, no implant. When I say high smile, I mean something where the mid-facial tissue is visible. Okay, Rob?
Okay, thank you so much. Dr. Elaskary, we have a question from Dr. Nas. He's asking, can you please explain how you are salvaging buccal wall defect, and what mixture of bone are you using, type of membrane and type of tats?
Can you repeat the question, please?
Sure. He's asking, how are you salvaging buccal wall defect, and what kind of bone are you mixing together, and what type of membrane and what type of tacks?
What type of tacks is I use BioHorizons Auto Tack. What type of membrane is, as I said before with Dr. Tarnow, I use 4 or 5 choices of flexible sheets of cortical bone. And then regarding the bone mix, that's what I used, 70% of autogenous chips with 25% of deproteinized bovine bone.
Perfect. We're going to move on to the next question from Dr. Fernan, is asking Dr. Tarnow about the dual zone bone grafting. In the case where you did use a xenograft, why did you not remove the particles left in the sulcus? After 6 years follow-up, the outcome was more than decent, even though the particles were left there.
I didn't want to take them out because it would create a void and they get collapsed in. So I let them heal. It was a thick enough tissue where it was coming out the sulcus slowly, like little particles over the year. So I just let them come out naturally. Now the problem is, the reason why we stop with the xenograft is sometimes, I didn't show any case like that, but sometimes we'll see a buccal fistula form on the facial. It's the one problem we've had, and it's rare, but we do have it once in a while when we do the dual zone. But the body can't get rid of that particle like a xenograft. And that's why in the soft tissue part, we don't like the xenograft there, because it might work its way out on thin tissue, out the buccal, and come out like a little splinter and wind up with a little infection. And then we have to kind of clean it, curette it, and we may or may not get a little recession when that happens. So we don't want that. When we use the small particle mineralized cancellous bone, it holds the tissue out, but it can be resorbed by the body. And so the body can incorporate it into the free gingiva and get thicker, but the particles can work their way out, but the body can get rid of it, where they can't get rid of the xenograft supracrestally. We're talking about something new now, which we're doing. I call it dual zone, dual graft, dual zone therapy. Dual zone, dual graft therapy. So dual zone, yes, but dual graft. So we might want the non-resorbable material into the bony part of the graft. In other words, up to the crest, the bone, like a xenograft, or something cortical like that. Like the chips that Elaskary talked about. So, but in the soft tissue part, we may then pack the top part, the top 3 millimeters, with something like Miniras, where we have small particle cancellous bone that will thicken the tissue, which is what our goal is, but the body can get rid of it if it wants to without having to pull through the front, okay? We're calling it dual zone, dual graft technique. That's coming out. To be continued.
To be continued.
That's next year's article, right?
I look forward.
There's a lot of stuff to be continued in this lecture.
Yeah, all the exciting stuff comes from this man.
No, look who's talking. What's exciting is about, even at our point of our careers, it keeps evolving. There's always some room to improve. And that's even though things are working beautifully, like you saw, 95, 98% of the time. There's that 3% to say, can I get even better? And that's really what we're talking about. And I think that's why you're changing over the years, I'm changing over the years. And eventually, we get we try little things that will improve. And I think that's what you always have to look at. But we're looking for something for the standard, 90+% of the time. I think you got it. What I showed is what I'm talking about. Okay.
Dr. Elaskary is definitely changing a lot more white hair than before. So that's one thing that's changing. All right, we have one more. We have a question for you, Dr. Elaskary. Dr. Tariq is asking, so are you completely against PET?
What's PET?
Partial extraction therapy.
Oh, PET. You're talking about,
like socket shield.
Socket shield.
I will give a little bit of an answer, and also I will let Dr. Tarnow continue on that, because I am interested to know what does he think. My opinion about socket extraction therapy is that it's a wonderful technique, and it's a very good technique, but it's very limited in its clinical applications. I don't find so many cases that has these criteria, that is already a clean socket, no infection, whatever, then why should I extract this tooth? So it's going to be like very limited, but it's a very good idea, and I respect it very much. That's there's no objection towards any technique, because any technique has a sense behind. And I would like to hear Dennis's comment on that.
Yeah, I think that it's a very intriguing piece. Marcus Hertzler deserves a lot of credit. Two of my students were involved with it, also Mitsias from Greece, and Notice was on the first article with him, and it was done 10 years ago, actually, about that time. And there's a place for it, but you have to be careful with it. There's a couple of things that are unknown. But it works, it's beautiful, because the buccal plate is not being destroyed and the tissue is being held out. No, it's very technique sensitive. And in other words, you got to get the apex and the palatal part out without disrupting that piece of buccal shield, but the piece that you're leaving in. My thinking is, everything has a place. And that's what I would tell my students. Everything's like another banana. Every procedure you learn is another banana. I call it be like the banana man. And you got to pockets stuffed with bananas. And every procedure you ever learn is another banana. You put it into your pocket. And treatment planning is figuring out, and what gives you experience tells you which banana is best for this procedure. Which one am I going to pull out for this procedure? And where would that be the ideal? Is there a place where it's better? Obviously, when it works, it's great because you don't have any change in the buccal contour. When it works, it's obviously gorgeous. But it's much more technique sensitive for most clinicians to leave that piece of tooth undisturbed and so on. However, I was thinking a lot about it. Two places where I think might be the ideal place, and I've done it in a few cases like this. I didn't show it today. Didn't have that much time. But one is where the tooth is ankylosed to the buccal plate, and to take it out would destroy the whole piece of buccal plate. You'd wind up with nothing. Then you would have to do something like what Dr. Elaskary's done. Are we finished? So thank you for attending. I don't know what that is. Okay.
No.
No, we're still here. We're still here.
You're still here? Okay.
Yep.
But here's the other piece. Where might it be perfect or be the best choice if you can get it done? That is where you have to take a tooth out for whatever reason. It could be fractured on the palate, could be a palatal periodontal defect, Could be an apex that we can't clean out, but you can leave that buccal piece and it's intact, and there's no probing depth on the buccal. It's intact, never been touched. Where would I say that would be ideal, maybe better than other things? That is if I'm going to take that tooth out, if it has a buccal dehiscence, meaning there's attachment there, but it's a very prominent tooth and has very little, no bone for 5-6 millimeters up on the CAT scan, and you sound the buccal plate, you see there's no bone. Not usually it's 3 millimeters up from the free gingiva. Let's say it's 5, 6, or 7 millimeters up, but it's intact and healthy. That might be the ideal place to do it. So you're not making a type 2 defect out of it. But you take the tooth out, you don't have any buccal plate there. So you take it out. Now you have to do ice cream cone or build up or a Scarry's technique or vestibular technique. Whatever it is, you have to build that buccal bone up. But if you leave that in, you don't have to touch anything. And if you can leave that in and leave it secured in there and get the rest of the tooth out, in a case where there's a buccal dehiscence but a healthy buccal tissue that's never been operated, that might be the ideal place for it, I think. And so that's where we're looking at. That's the ideal place. It might be the number one treatment when, whereas if you take that buccal tooth out, the buccal piece of tooth out, you're going to wind up with a buccal defect and then have to worry about building up the bone. So I would say that I presented that at the Academy of Periodontology about 6 months ago as the place that might be ideal for that kind of thing. So I presented it there. You know, your thoughts, Bill? Bill? That might be the ideal place. You know, it can be done in any tooth, but you know, if you want to, but it might be the ideal place, better than other techniques. Therefore, you don't have to rebuild the buccal plate. What's better than that?
I have a little question for you.
Yeah.
If you have a gap, a buccal gap of like 3 millimeters.
Yeah.
From the interface of the implant to the buccal edge of the labial plate of bone, and this patient has thick phenotype,
right.
What would you do? Would you fill this gap, or would you just let it to fill with whatever blood clot, whatever? I know the literature quite well, but I want to know, what would you do in your practice?
If it's real thick and I have that gap and it's not in a big cosmetic area, it doesn't matter. The only thing that the graft does is helps keep, if there is any change, it's like an insurance package. It's like when you have thick bone, it's probably not going to go much further. But if you're worried about it, especially if it's in the aesthetic zone, like a high bite, like bicuspid or first bi, then I'll put the graft into the gap, similar to what we did. So today we graft almost all the gaps, and I think that way we're never worried about the change in the ridge shape. You know, not worried about how thick that buccal plate is. We just assume that they're all thin, even though some we know, like you said, 10% of them are thick, and it might not be necessary. In the molars, when we do molars, like, I didn't get to that, like you showed one today. When I do molars, I don't worry about the gaps at all. It's not a cosmetic area. Just make sure the clot is there, put a custom healing abutment on, or a low temporary, and call it a day. Let the clot be protected by the eye shell, what they make for molars now too. Put it in, a little light cured composite, round off the bottom, screw it down, and you're done. In 5 or 10 minutes, you're done with that. And even if you're not going to put the temporary on, and that's what we do with the eye shell. You know? So it keeps the tissue open. Then we come back in 3 months and take an impression and finish the case. So, but I don't gap those. Those are big gaps in the molars. Assuming the buccal walls are there, of course. Those are big gaps because of the shape of the opening, and so I don't worry about them at all. Those are classics. We don't fill it. Good question.
Thank you. Good question. Okay, we have about 4 minutes left. I'm gonna use these 4 minutes to have Dr. Elaskary and Dr. Tarnow kind of give us some final remarks, or one thing that you think the audience should take out of this whole session. What would it be? We can start with you, Dr. Tarnow.
Okay. First, let me thank you again and thank Dr. Elaskary. Abdul, thank you so much for being there and being such a good friend. And thank you for the lovely introduction. I will have to have you come with me and introduce me anytime. That was great.
It's the reality. I'm not exaggerating.
And I told him I'd give him $1 for every time he mentioned it. I owe him $3 now. Okay. But the real thing is, if you're looking at everything, and if you look at both of our presentations, we're thinking biologically. We're not just thinking, as mechanics. We're thinking about wound healing. We're thinking about blood supply. We're thinking about biology. And that is the real take-home message. You've got to be a great carpenter, and we have to show you what burr to use. We have to show you what implant we like, but those will change and those are manipulated. The key is always think biologically. And if you do that and understand why you're doing what you're doing, not just how to do it, And always remember you have a patient in a chair, not a piece of meat. You treat a patient, not just a procedure. Those are the things that are the take-home messages always, never change. That'll be now, it'll be long past when we're gone. If you think biologically and do the best clinical dentistry to match the biology, you will be a great clinician and treat people as human beings, not as procedures. I think that's a good way for me to end. Abdul?
Yeah, for me, I believe that we should look at immediate implant placement in the aesthetic zone on a comprehensive look. We just cannot look at the socket only. You have to look at the occlusion. You have to look very importantly at the tissue phenotype, because this is what being overlooked all the time. I need to look at the tissue phenotype, and I need to emphasize the fact that I need to modify it or to enhance it if it is thin. Also, I need to take care of to minimize the level of the osteoclastic activity in the procedure in general. Osteoclastic activity occurs with tooth extraction, with flap reflection. I am probably against flap reflection 100% whenever possible, as Dr. Tarnow said. And that's for all of it. And I look forward, Dennis, you should make sure to invite me sometime at Colombia when things open.
Consider it done. I know you've been there a few times before. We love you guys. Thank you so much. Stay healthy, and stay healthy, everybody. That's most important.
Thank you very much. Thank you, Dennis. Thank you, Ralph, for the wonderful invitation. Wonderful day, and thank you for the organizers. Really have done a great job.
Yep. Thank you all. And again, I want to thank the organizers. This doesn't happen in a day. So I want to send a special thanks to Melissa. I want to send a special thanks to Andrea as well, and all the team involved and the graphics team, and a special thanks to our speakers today, Dr. Tarnow and Dr. Abdelsalam Elaskary. It was amazing. Thank you for your time, and we'll see you next time.
Thank you very much.
Thank you.
Tarnow, I like you, Dennis.